We are live.
Good evening. Welcome to Retinoblastoma 2024. This is an international symposium. Obviously, this is the International Retinoblastoma Awareness Week that is coming up from May 12th to 18th. And this is in association with the International Retinoblastoma Awareness Week. It's an event in association with that. And this also includes a retinoblastoma quiz. And this particular symposium is organized by the All India Ophthalmological Society. Chairperson for the symposium is the president of ISO, International Society of Ocular Oncology, Dr. Dan Gombos, who's from MD Anderson Cancer Institute, Houston, Texas. And co-chairperson with him is Dr. Ashwin Reddy from the Moorfields Eye Hospital. We have moderators, Dr. Fairuz PM from Bangalore, India, and Ritika Sain from Chennai, India. We have the entire spectrum of elite faculty: Ashwin Malipatna, Swati Kaliki, Matt Wilson, Amita Mahajan, Carol Shields, Mahesh Shanmugam, Francis Munia, Bhavna Chawla, Jesse Berry, Rachna Meal, Ralph Eagle, Kaustubh Mule, Murli Chintagumpala, Helen Damaras, Usha Kim, Didi Fabian, Sima Das, and quiz will be conducted by Dr. Olika Bansal. Each of them will be introduced as their talks come up. So we begin with actually a panel discussion. It's a 1 hour discussion on the spectrum of retinoblastoma. We'll show you case examples and then ask the faculty to go ahead and discuss as to how they would deal with each of these clinical situations. Last time when we had it a couple of years ago, we hoped to cover the entire spectrum of RB, but we could just get to group C because there was so much of discussion in group A and B, C, and that couldn't even go to group D so much. So this time we're going to start with group E and go down. Group E, if you could complete, and then probably go to group D as well. So these are the talks that we have for today, and of course that's the final quiz in which everyone can take part. It will be on Kahoot platform. So we'll start with the panel discussion. Start with group E retinoblastoma. Now this is a case, a 3-month-old child, male child, with right eye group E retinoblastoma with euphthalmos with neovascular glaucoma. There is no optic nerve extension visible on MRI scan. There's no pinealoblastoma. Left eye is group C. So how would you manage? Any thoughts? Let's start with Ashwin from
London. Hi, Santosh. Thank you very much for your invitation to be part of this excellent symposium that you've organised. So in London, we'd be giving systemic chemotherapy. Mm-hmm. And part of that is the great work that you've done and the papers you produced in this area. And we've had lots of MDT discussions about this. And over the years, it used to be an outlier to treat this and not just to nucleate the right eye. But over the last year or so, we've moved to giving systemic chemotherapy for salvage because the group C eye might be difficult to control, might be removing that eye. The group E eye might actually do extremely well, and we could salvage that. So that would give this child at least one eye. So that's what we do in London. Hope that helps, Santosh.
Would you be concerned about the presence of neovascular glaucoma up front? Would you consider it as a clinical risk factor? And of course, you would do MRI and you need to rule out if there is choroidal invasion, massive choroidal invasion, optic nerve invasion, and ciliary body involvement. If none of that is there, you would be comfortable giving systemic chemotherapy.
Yeah, I mean, we'd see after every cycle, mm-hmm. and we'd expect a response. The ones I've seen is quite impressive, really, because we always assess the horizontal corneal diameters, and to go from 12 to 11 is quite impressive, really. And we watch these kids very closely at all times. So, and the pressure, you see the pressure going down. Recently, we had one that had a high femur after one cycle, a complete high femur. We had to enucleate, but we always give the option.
Dan, would you deal with this case differently?
Yeah, I mean, I think what's presented is a very reasonable approach, and we would probably consider the same thing. There is a small cohort of patients where you will see the neovascularization regress. If it's just a size component and the tumor sort of shrinks, sometimes you'll see that improve. I think the prognosis for the EI is still guarded at best. We would equally present to the family, the potential benefits of understanding that enucleation will provide definitive histopathologic information. And, you pointed out that the MRI was not of concern, but if the MRI was of concern, then, you might want to tilt toward enucleation under a situation like that. So I think in this instance, what's been presented by Professor Reddy is very reasonable, and we would probably go down that route, but we would very definitively look at the MRI scan as well and make sure that there was nothing of concern on that area.
All right. If MRI were to show choroidal invasion and ciliary body extension and maybe a couple of millimeters of optic nerve invasion, would you still give intravenous neoadjuvant chemotherapy and defer enucleation beyond 6 cycles, or would you do upfront primary enucleation?
Yeah, so, and this comes up many times, and we used to have an approach where we would give neoadjuvant and then consider enucleation. But our team overall has said we'd rather deal with whatever the real histopathology is, as opposed to potentially masking what the true histopathology is.
Mhm.
And although I think we've gotten better at predicting what is high-risk histopathology on neuroimaging, I don't think that we're at the point where we can definitively say that even with the best of neuroradiologists, it is the equivalent. So if we ultimately came to the decision that this eye had to be enucleated and we wanted to do that up front, we would do that up front, irrespective, and provide the team with the accurate histopathology, understanding that that might even include cut-end disease in some cases. But we've seen over and over again that a lot of times neuroimaging will inaccurately predict the extent of disease into the optic nerve. You'll get a lot of edema, and that edema can be misread by neuroradiology.
Right. Mahesh, you had something to say?
I would look at it this way. The left eye anyway needs chemotherapy. So there's no harm in giving 2 cycles of chemotherapy and seeing if there's a possibility of salvaging the right eye. So, and there, as Dr. Ashwin and Dr. Dan mentioned, there's still a possibility that the right eye can be saved with vision. So anyway, the other eye needs chemotherapy. No harm in giving chemotherapy and then seeing.
Right. So we have 2 pediatric oncologists in the group, Amita and Murali. Amita, would you have any concerns about giving systemic chemotherapy to a 3-month-old child with bilateral retinoblastoma? Murali?
I'll have Amita go first.
Okay.
So yes, concerns, yes, but we have given it, and there are suggested dose modifications. So we have to modify the doses. It is more challenging, but in this situation, yes, we have done it in this kind of setting, and it is doable. The tolerance is not an issue for us to give it giving it may be a little challenging in terms of venous access and other issues, but they do tolerate it with the modified dose regimen for babies under 6 months of age.
Mm-hmm. Murali?
I agree. One of the, I think your concern is that this could be masking high-risk histopathologic features, which you cannot see on the most sophisticated MRI. Granted that this kid might have high-risk histopathologic features, but you're covering well with systemic chemotherapy. So even if there's microscopic disease that's spreading or about to spread, I think a couple of cycles with higher doses of systemic chemotherapy that we generally give for this advanced eye, that should take care of it. I agree with the previous speaker, Dr. Mahesh, to give a couple of cycles and see. I mean, if there's no response, obviously, as Professor Reddy said, you would enucleate, and Dan said that too. But I have no problems initiating systemic chemotherapy because you're going to provide adequate coverage for any spread that is likely to occur.
Ralph is also online, so let me ask him. Ralph, can you unmute yourself if you're around?
I'm sorry?
Right. So I wanted to ask Ralph a question, but I think he's...
Oh, Ralph.
Yeah, so he's offline. Anyway, so histopathology is a concern that we agree, and unmasking of the histopathological risk factors, masking of the histopathological risk factors may be of concern. But since we are giving 6 cycles of chemotherapy anyway, The dictum is that if you begin with intravenous chemotherapy, you have to complete all the 6 cycles. Otherwise, as has happened in a Chinese study, which was reported, if you cut short chemotherapy and then enucleate, and then you don't find histopathological risk factors, you don't do any further treatment, then the child may have a higher risk for developing systemic metastasis. So that's one of the issues. Didi, you wanted to say something. You have raised your hand.
Yeah, so it seems that we all agree with Ashwin. I too agree with them. So in the past, we used to enucleate the right eye, the advanced eye, and try to preserve the group C eye, and today try and conserve both eyes with systemic chemotherapy. I wonder if we're going, I mean, that direction, would anyone treat with intraarterial chemotherapy for both eyes? We know it's much more effective. And if we're trying, of course, there's the issue of systemic micrometastasis, but if we're trying to save the EI, that's much more effective. Personally, I would give systemic chemotherapy and then monitor the patient and see, but it is another possibility.
Well, I would go to intraarterial chemotherapy, perhaps if there is significant residual in the worse eye, group EI, following 6 cycles of intravenous chemotherapy. That's when I would, if it is at that time salvageable, appears salvageable with 3 cycles or 4 cycles of intraarterial chemotherapy, perhaps you would go on that, because the issue is always about microscopic metastasis. In an eye with ophthalmos and neovascular glaucoma, even if MRI is negative, MRI is not 100% sensitive or specific, there might be risk factors which obviously would go unnoticed, and intraarterial chemotherapy would not be able to take care of micrometastasis. So that's the concern that I would have in treating this child with bilateral IAC. Any difference of opinion? Seema?
Another thing is that the IAC, if you like, is safer in an older child. So you've also built time for the vasculature and the IAC to be, I would say, easier. You know, I don't know anyone that's done IAC in a child less than 3 months. You're sort of just at the border of where you would consider it. And I completely agree with your approach if you're going to want to include IAC in that regimen.
Rachna, do you have any thoughts on this?
Yes, Dr. Hanauer, actually, this is a 3-month-old child and it's a bilateral RV. I'm sure there's also a concern of a pineroblastoma developing later on. So I think the systemic intravenous chemotherapy may also avoid that or delay that or take care of that. There is no strong evidence, but the incidence has gone down after the systemic chemotherapy has become the protocol for treatment. So yes, I agree. Intravenous chemotherapy is the one to go with.
Ralph is online now. Ralph, can I ask you a question? Quick question. Ralph, can you unmute yourself?
Yes, you're asking me?
Yeah, so I wanted to ask you, this was a child with bilateral retinoblastoma, one eye, right eye, group E with neovascular glaucoma and ophthalmos. We gave intravenous chemotherapy and obviously the tumor responded very well, as you can see here, and nothing else happened. So, but MRI was also negative in this patient. But suppose you have a child like this, you know, this is the appearance at primary visit. Would you be worried about masking of histopathological risk factors if you were to give neoadjuvant chemotherapy? Is that a real concern for a pathologist?
Yeah, I think there's always a possibility of that. We don't. The problem is we're not seeing that many specimens anymore. I'd like to know. Ask Dan, how many nucleations have you seen this year?
There's no doubt that there's a significant reduction in the amount of eyes that are succumbing to enucleation, but this is in fact the exact type of scenario where we really need to think about that because we're either potentially not going to get the real histopathology, and then we're always going to wonder, or if this eye does come to enucleation, we're then going to be questioning the histopathology. So this is sort of the exact scenario where we're left in hand, where we're sort of, in some ways, sort of obligated to, in some ways, assume that there's going to be high-risk histopathology from that perspective, even if this eye is well treated.
But if you give 6 cycles of VC, does it matter if part of it is given neoadjuvant and part of it is adjuvant? So whether it's primary nucleation or not, I mean, if you cover the patient with systemic chemotherapy, then that's what you would do in case of high risk histopathology features after primary nucleation. So I'm not sure it makes a difference.
Right. No, that's perfectly all right. But then if the child were to have, for example, scleral invasion, we wouldn't know. MRI is good, but it's not 100% sensitive or specific for scleral invasion, or a small extrascleral extension, in which case you are supposed to give a higher dose neoadjuvant chemotherapy. Here, we assume that the child doesn't have any of that, and we give standard dose chemotherapy. So if a child of this sort were to develop systemic metastasis, would that be an issue? Medical legal issue, because this is the kind of cases that we deal with on a weekly basis. It's quite common in Asia, this part of the world. So we want some pearls.
How about other non-medical factors like potential compliance to therapy? Would you be more likely to enucleate in such instances?
Right. So of course, those are issues. Those are issues that we deal with. And if a particular set of parents are not keen on enucleation, then that's fine. But if they're left the decision to you, and the child ultimately does well in the eye but develops systemic metastasis, so that's going to be an issue, right? So how do you deal with counseling a set of parents like this? Any thoughts? Seema, what would you do?
So I agree with what the rest of the speakers are saying. In our setting, typically we go for systemic neoadjuvant chemotherapy, and based on the response, we decide upon the course of action. I think one of the reasons of giving the IV chemo is also not only the response part to the treatment, apart from the histopath high risk factors and rest of the features which we are talking about, it's also important from the compliance point of view. We know that in bilateral case like this, where we know that at least one eye is salvageable, sometimes the advice of upfront enucleation just makes the patient run. At least that's what we have seen in many times in our setting. So in those cases, at least giving 1 or 2 cycles also gives the family some time to get sort of adapted to the idea of enucleation. And sometimes they accept the advice of enucleation more readily. So that could also be one of the reasons where we can probably improve the compliance.
Okay. So consensus seems to be that for this sort of a situation where there is asymmetric retinoblastoma, one eye having group E, bad group E retinoblastoma with or without neovascular glaucoma, with MRI being negative for massive choroidal or ciliary body invasion, scleral extension, or reasonable optic nerve extension, then the consensus is in favor of neoadjuvant intravenous chemotherapy, but complete 6 cycles, and then reassess the child as to what else could be done, maybe intra-arterial chemotherapy to help resolve the residual retinoblastoma in the bad eye, maybe plaque brachytherapy, maybe enucleation at that stage. And then, of course, you would reassess histopathology following enucleation. And suppose there are high-risk factors despite initial 6 cycles of neoadjuvant chemotherapy, then what do you do? There are residual high-risk factors. Suppose you have enucleated this eye now because it's refractory, and then you find that there is massive choroidal invasion, then how do you deal with it? You're already given 6 cycles of neoadjuvant chemotherapy. Murli, you led a very large...
I do think, it's a scenario like this where having an ocular pathologist really part of your tumor board is so critical. So, we have Patty Chavez-Barrios in our group. She presents each and every histopathology slide, and she will come to us and she'll say, yes, this is high-risk histopathology standard. And then here's a case where it's really bad and I'm really worried. So what are some of those such scenarios? She always talks about the perimeningeal vessels that penetrate externally right around the optic nerve. And sometimes she will see microscopic disease. And to Didi's point, I don't think that all high-risk histopathology is the same. I really see when our ocular pathologist, and Ralph can maybe talk about this, there are differences. There are ones where she comes and she says, there is massive choroidal involvement, or I'm really concerned about these cells that are right around the perimeningeal vessels. And then we will review, and I think that goes back to what type of chemotherapy you gave up front. Because remember, there's lower dose, higher dose. You might not see residual microscopic disease if you didn't nucleate this eye up front. Maybe it was there. In the perimeningeal vessels, we've seen those cases, rare cases, ultimately become metastatic to the CNS. Do you add radiotherapy under those exceptionally high-risk features? I think in most instances, we just say we gave it. But I do think not all high-risk histopathology is the same, and we're sort of lumping it together. But there is bad and then there's really bad.
Right. What's your threshold for enucleation in a group E retinoblastoma with a large mixed endophytic exophytic tumor occupying more than 75-80% of the vitreous cavity with total retinal detachment and no visual potential? If it's unilateral, what is your threshold for enucleation, Seema?
If it's a group E and the anterior segment involvement is not there, there is no neovascular glaucoma. Even if it's unilateral, I think then it's worth giving a trial of SEM. But if it's a visibly non-seeing eye, neovascular glaucoma, frank invasion of the anterior segment, and if talking to the family, you get an idea that compliance might be an issue, then of course, front enucleation is possible. That's what we like.
Ashwin?
Yeah, so it's this E's and D's and D's and E's, and it's what Ashwin Malipatnam's going to talk about, this AJC 8th edition. So, what I really want to know is there Booth-Thalmos here, and is there neovascular glaucoma here?
No,
Then we would salvage.
We would try to salvage. 9-year-old child, is that a concern? 9-year-old child, older children don't respond so well to chemotherapies.
Yeah, I mean, in UK, we can guarantee follow-up, and we can see them after 1 or 2 cycles. And with the group, we would call this group D with the other IIRC, but we call it CT2B. That's what we call it in London, actually, CT2B. And for that, we'd be giving salvage in the first instance, and then we'd be following up.
Mahesh?
And if they don't respond, we'll go to enucleation. The parents are happy with that. At least we tried.
Right.
I'm not too concerned about metastasis in CT2B.
In our situation, there are other factors which come into play as well. One is a girl child. The parents are not keen on having enucleation of a girl child. That's number one. Second is the socioeconomic status of the parents. So if they're able to go ahead and follow up, have the wherewithal to follow up for the next 1 or 2 years with repeated GA examinations and chemotherapy, and how much of a strain it will be on their personal finances is something which we need to take into consideration before we attempt saving an eye, which maybe is possible to salvage, but then without vision. So if the parents are extremely keen, I give them the option of about 2 cycles of chemotherapy to see how it responds. That gives them a buffer time for them to make up their mind and also accept the fact that this eye may have to be enucleated. So these are situations which we have to take a decision as we go along with it.
Absolutely. So she did well, actually. She was given intravenous chemotherapy, and you can see very nice response after completion of treatment. Even the optic nerve seems healthy, and macula is fairly healthy, and she developed some vision. She had about finger counting 2 meters kind of vision. Of course, intraarterial chemotherapy would be great in this situation. But, in this particular region, finances are a concern, and intravenous chemotherapy costs less than 5% of intraarterial chemotherapy for a patient who has to pay out of pocket. If the patient is insured, it's fine. Otherwise, that becomes a concern. So either which way, these eyes can be salvaged. That is one of the lessons from this particular patient. Let's go on to vitreous seeds. A patient with retinal tumor nearly totally regressed, but a bunch of residual focal vitreous seeds. How would you manage? Ashwin Malipatna, you're on. Ashwin perhaps has stepped away.
Sorry, no, I haven't stepped away. I was taking a moment to find my microphone.
Okay, great.
The scenario again is that we have vitreous seeds now.
Yes.
That is post-treatment.
Post-treatment, and the retinal tumor is nearly totally regressed. It's no longer a concern, and the residual can perhaps be treated with transpapillary thermotherapy. So the concern is just this: after chemotherapy, systemic chemotherapy, this is what we have residual. So how would you address these vitreous seeds?
Okay, so I think these are cheesy vitreous seeds, or these are the, and I see one sphere over there for sure. So this looks like active vitreous seeding to me. And if it is active vitreous seeds, and if it's not, refractile dust-like, or maybe just speckled in some way, then I do think that some intraarterial chemotherapy is warranted here. Some intravitreal chemotherapy is warranted here. And intravitreal injections, of course, melphalan is probably the oldest choice with some evidence over there. But you also have topotecan that you can do as well intravitreally. However, I do see that around the tumor there's a cuff of around the calcification that's nasal to the calcification. You do have a cuff of some tumor activity. I do believe that the retinal activity needs to be addressed as well, in addition to these vitreous seeds. So if you do have, if you do want to address the vitreous seeds, then I do think addressing the retinal activity primarily is important to prevent more seeds from coming up. So if you feel that the retinal activity hasn't been dealt with as yet, then I think intraarterial chemo or something additional over and above what has been provided will be something that I might recommend.
Okay, great. Didi?
Thanks. So I too would treat with the intravitreous melphalan. In this specific case, I assume it would be 20 micrograms. And monitor carefully. I'm not sure what's the status of the fellow eye, but the macula here seems not involved, and we all know that melphalan is very toxic. And easily after 2-3 injections, he can develop an ERM or lose vision iatrogenically. So we need to bear that in mind.
Right. So intravitreal melphalan was what was given in this child. This was one of my early cases, and she did well with a couple of injections. How do you dose intravitreal melphalan, and do you have any escalating dose schedule? How frequently do you inject currently?
Me or?
Me, I mean, you, of course.
Me, you, yeah. So actually, we use 3 drugs. So topotecan, melphalan, and carboplatin. Sorry, for intravitreal. That was for intraarterial. No, so we use melphalan. It could be 20 or 30 micrograms. It really depends on whether there's a lot of the seeds, dust, fair clouds. Or for this case, for example, I would treat with 20 micrograms weekly and monitor the case. So I would stop at a certain point. The issue is, in some cases, it stays stable. I mean, the picture doesn't change. The seeds, you're not sure if they're active or not. And if you continue to inject, again, you can damage vision. In this case, I assume it would be between 4 and 6 injections.
Ashwin?
I think for us it is melphalan 25, and it is every 4 weeks to start with, to see how that responds. We don't do weekly. I think we're a little nervous about the toxicity if it's weekly. And I think if we want to really go quicker, we might even go to once every 3 weeks perhaps, but I think once every 4 weeks is what we would do until we see activity.
Ashwin from London.
Yeah, the other Ashwin. So the issue here is the half-life of melphalan. So there are some centers that where the surgeon will actually make the melphalan by the patient, set it up, and then give it immediately. When that is done, and that's what Shigenobu Suzuki was doing in Japan, where obviously intravitreal chemotherapy came from. That's where the theory came from, the hypothesis. So the issue with that is obviously you're getting quite a toxic, the half-life is such that it's very, very potent. And the issue we have in London is that if we're not allowed to do that. So we have to get it developed by pharmacy, and then we have to make sure we can't send for the patient for the examination and anesthesia until we're sure that pharmacy has got it made. And then we have to transfer it to us, which can take over an hour. So when we're looking at doses, we also need to know when it's being manufactured and how it's being manufactured. Now, the advantage of having pharmacy do this is they're going to be very accurate. And I'm not saying surgeons won't be very accurate, but they've got other things to think about. So there may be some errors that may come in, and again, that will affect the potency and the toxicity. And to cut this story short, before we waited until it was examined by one of our nurses before they came in, IVC was very, very successful, and we had a very good success rate. When it was delayed, we found our success rate went down. And that's, I think, and the team thinks, relates to the potency of the melphalan. So what Francis Munier does is he has frozen melphalan on hand. So I think in any discussion about melphalan, we need to have an understanding of how it's being manufactured, who's making it up, and how long after makeup it's being made, it's injected in the eye. I think that's really, really critical. And because we've audited our results, we're going to topotecan now. And so we're stopping melphalan until we can get it into the eye much, much quicker.
Do you think periocular topotecan works? This was a 7-year-old female, Group E retinoblastoma, status post intravitreal intravenous chemotherapy, 6 cycles. And you can see, of course, intravenous chemotherapy would have helped to a certain extent, but we also gave additional periocular topotecan with every cycle of intravenous chemotherapy in oblique meridia between the recti, avoiding the supratemporal quadrant to avoid the lacrimal gland. And the vitreous seeds completely calcified over a period of time. So is that something that you would do or you would not do at all? When the child is on intra-arterial or intravenous chemotherapy with an active retinal tumor, you cannot go into the vitreous to inject the drug into the vitreous. So would you give intra or periocular topotecan or periocular carboplatin? Do you believe at all that periocular injections work? Mahesh?
I personally don't have any experience with this.
Mahesh?
Yeah, periocular injections do work, but I don't have any personal experience at all, because I think you have published quite extensively before the intravitreal. So periocular does work. I have seen patients. Only concern is like when these eyes come to enucleation, becomes a bit of a difficulty because there are some adhesions in the area where the periocular drug was given. But otherwise, yes, periocular does work, and it's probably a reasonable option, particularly the situation you mentioned when the child is already on intravenous chemotherapy. About the earlier case, if the child is already on intravenous chemotherapy and intravitreal melphalan adds to the risk of the retinal toxicity, that's another thing which we need to take into consideration as well.
Rachna, Seema, any thoughts? Do you believe in periocular injections?
Yeah,
carboplatin, of course, carboplatin does have a lot of, periocular fibrosis, ocular motility restriction. But with topotecan, we don't have those concerns, especially if it is injected deep posterior subtenons. So,
yes, so there was a study at a center where we did periocular topotecan along with intravenous chemotherapy, and it does seem to have a good promise, at least initially, but we don't have we had a follow-up of only around 8 months, a mean of 8 months. So we can't really say how it would be in the long run, but at least at this much of a follow-up at the end of treatment, I don't remember exact what percentage was it, but a significant number of patients did show a very good response the way you've shown here in this case.
This was also one such similar example where all this bunch of vitreous seeds went away along with, of course, intravenous injections, but you can see nice response of vitreous seeds as well. So we actually had about 68% remission in vitreous seeds along with intravenous chemotherapy when periocular topotecan was given. This was published. So I just wanted to know the group's consensus as to whether they would use this approach ever at all or not. So let's have some Western perspectives. Dan, Ashwin.
So, the COG trial, group C and D, clearly demonstrated that periocular chemotherapy worked, but it was abandoned because of the horrific toxicity. Some of the hardest enucleations I ever did were post-periocular carboplatin.
Right.
So whether it's good or bad, it has soured a lot of people's memory to any sort of periocular chemotherapy, although it's not appropriate to make that jump to periocular topotecan. I had a very advanced group DI with seeds really 360 degrees, and our approach really was to go very hard on intra-arterial chemotherapy, particularly pushing on a higher dose of melphalan to try until we can get a quadrant where we could safely inject intravitreally. And that would be, I think, an alternative approach if you're going to go down the IA approach. Very often you just need to get 2 or 3 clock hours where you can then inject safely, and then you can sort of salvage. So I think more commonly we would see people trying intra-arterial chemotherapy to try to open up that quadrant. If they can't open it up at all, I think is another approach. And I think, the other thing is that we have an enormous amount of data on the therapeutic window, but there is enormous disparity on what people do, as you pointed out. So we know that somewhere between 20 and 30, let's say, of melphalan is a therapeutic dose. We started out for a long time at 29, and I never had any serious ocular complications, although I had multiple colleagues tell me that at that dose they had seen pretty horrific complications. The COG trial went to 25, so we've now gone to sort of 25 to 26, but I know that there's some US centers that will not go above 20. So I think somewhere between 20 and 25 melphalan is the dose that many people use. I think one of the challenges of doing weekly treatments are you're not giving enough time between treatments. We know that there's a delay. We know particularly clouds where there's a lot of necrotic tissue need a period of time to clear up. So I think you need to give some period of time, and you don't need, we've learned that you don't necessarily need to completely clear the seeds to, stop therapy and see what the response is going to be. But I think what you're alluding to is there isn't a uniform approach, there isn't a uniform dose, but I have seen a trend toward a lower dose of melphalan and perhaps less treatment cycles than we did maybe 3 or 4 years ago.
How many of you have seen this kind of a complication with melphalan? This was 20, and you can see extensive retinal pigment epithelial atrophy. This child did not have exudative retinal detachment to attribute all these RP changes to. This child had a group C retinoblastoma with focal vitreous seeds and then developed diffuse vitreous seeds for which intravitreal melphalan was given. And this is the end result. So
what dose?
20. This seems to be more common in pigmented eyes such as ours, Asian, Indian eyes, African eyes, even Hispanics. Have you seen this, Rachna, Mahesh, Seema?
Yes, sir. Yes, sir. Very often.
Yeah,
What
very
dose?
often, very
At
frequent.
what dose? At what dose?
20.
20.
Same at 20. I have found this a little bit more common if the child is already on systemic chemotherapy as well.
Ashwin, ready?
Yeah. So we've never seen it, and we give 30 micrograms melphalan. So how are you making up the melphalan? Is that by the baby as soon as they're anesthetized?
No. So this is, everything you said, again, is no different for us. It's just how do we address the problem, which is you need freshly made drug when you need it. And so we have erred on the side of keeping the child asleep for a longer period of time, which is not great for operational aspects. But we say we sort of prep everyone. We say this child will likely need melphalan. We say make it now. And then usually within the next 20 to 25 minutes, we get it brought up fresh from pharmacy. And we actually have the time per minute when it's going to expire. So our goal is to get it in the eye within an hour of it being made fresh, and certainly no longer than 2 hours from it being made fresh.
I think that's really important, Dan. So thanks for that information, because I think that's absolutely crucial for this discussion.
Melphalan was injected within 30 minutes here, but that was not the issue at all. But we uniformly see, even in low dose Melphalan, these kind of complications, especially in pigmented eyes. So we have shifted over to topotecan. And I really want to know how many of you prefer topotecan over Melphalan in the group. Seema raises a hand. Anyone else?
Same here, sir. We also use most.
Melphalan. Ashwin has raised his hand. All right. So what is your preferred dose and schedule for topotecan? And what is your safety enhancement parameters? And what is your endpoint? When do you decide to stop giving intravitreal topotecan or even Melphalan for that matter? The last two questions could be common to any of the drug safety enhancement parameters and endpoint. But for topotecan, what is your dose and schedule? How do you triage dose and frequency? Seema, do you want to go first?
Yeah, so we start with 30 microgram. Generally, that's the standard dose. And if in the response is suboptimal, we scale it up to 40 micrograms.
Scale it up to?
40. 40 micrograms. And as far as the safety enhancement is the standard as any other intravitreal injection for retinoblastoma, a double freeze cryo, and the needle has to come out through that. And of course, then by water. We don't do an AC tap routinely before the injection because the volume of the injection is pretty low. So that's why we do it routinely. And we do give a pressure of the blood, and we do inform the anesthetist to give the intravenous on the left side during the time of intravitreal injections, which are pretty much standard for me.
Do you use only topotecan, or you move to using only topotecan, or alternatively?
Only topotecan. No, so we are using only topotecan. Melphalan, right now we have reserved it only if there is no response to topotecan as a second line.
So we use it as Melphalan as combination therapy in low dose Melphalan along with topotecan if the vitreous are refractory. If they don't respond within 6 injections of topotecan given 3 weekly, then we add on Melphalan or switch to Melphalan, low dose. So are there any other safety enhancement parameters would any of the panelists recommend apart from injection site cryotherapy? Death by water is something that I don't do personally, but would any of you prefer that as well? And would any of you give subconjunctival topotecan, just a small bleb of it in the area of injection? These are some of the safety enhancement parameters that are recommended. So
I do use distilled water. I do use subconjunctival distilled water as well as distilled water over the cornea as well as in the conjunctival cul-de-sac, leave it for 3 minutes. And at the end of the cryo, we can inject subconjunctival distilled water, subtenon. So that kind of stays there, and probably if there are any cells which have come out, that takes care of that as well. So I do use distilled water quite commonly.
Ashwin?
Yeah. Oh, yeah. Sorry. So David Abramson's doing high dose topotecan now. He's produced a couple of done a case series on that, and following on from that, we're using 48 micrograms of topotecan, high dose topotecan, because of this issue of Melphalan that we described. Santosh, you're using 30 micrograms, is that right?
We started with 30, then we went on to 45, which we found to be safe. Then we went on to 60 for diffuse vitreous seeds. And then now for diffuse vitreous seeds, which are like anterior, mid, and posterior vitreous, I've injected 90. And still absolutely no complications. So the highest I've injected is 90. We have a bunch of cases which my fellow is now analyzing, but that's the highest we have gone to, 90. 60 is quite safe. 90, I wasn't sure it would be safe or not. That was a situation where we had to otherwise think of enucleation. We found 1 clock hour where we could get the needle in safely, and that really worked. So encouraged by that. And also in patients who have epiretinal and subretinal seeds and small endophytic tumors, it works like magic. 90.
And what volume is your 90 micrograms of topotecan?
0.1. The same.
Just 0.1.
Same volume is the same. I mean, we just have to calculate it for that.
Oh wow, yeah. So I've got 48 micrograms in 0.12 mils, which is slightly more than 0.1. So we're always doing a AC paracentesis,
right?
But that involves cell-free DNA anyway. Right. So we're doing the AC paracentesis for the cell-free DNA. So we're doing two things at the same time as well, and so giving us a bit of confidence. But our pharmacy is not quite at the level to put 90 into 0.1. So that's really interesting. And I'm glad it works as well, because that's the impression all the research is showing. Welcome, Dr. Shields.
Yes, thank you. I would like to concur with what Santosh has said. We've been using 0.1, it's in 0.18 cc, 90 micrograms, but occasionally I've given 100 micrograms in 0.2 cc's. And Rolika Bonsal's on this call, on this Zoom too. She's been keeping track of all the cases. And I think we have about 10 cases of advanced vitreous seeding where we gave 100 micrograms of topotecan, 0 complications, and it really works. And I agree with Dr. Santosh, even small intraretinal tumors, we get results. I'm not yet convinced it works for subretinal seeds because often we're giving intraarterial chemotherapy at the same time, but it might. So I do think this is a great new alternative for injections.
What would you do when you're given 6 or say 7 or 8 injections of intravitreal topotecan, like this situation where child started off with massive vitreous seeds? This is at the primary presentation. And of course, tumor regressed with chemotherapy. And then this is a bunch of vitreous seeds that we have residual after 6 injections of intravitreal topotecan.
Yeah, in a case like this, we might even consider going high dose topotecan, even up to 100 micrograms. Sometimes if you keep your interval instead of every month, every 2 months, you'll start to see the calcification of the topotecan. You can, as you did, you can also add melphalan. I'm always hesitant to add melphalan standard dose 20 micrograms because I've seen every complication imaginable with melphalan.
Right. So this was an early situation, where we hadn't learned that melphalan would produce this complication, and we added on 20 microgram of melphalan. Vitreous seeds went away, but you can note this retinal pigment epithelial changes in this particular zone. So it does work in refractory situations where topotecan has stopped working. Well, somebody wants to say something. Dr. Shields, you have raised your hand, and there's somebody else. That is Ashwin Malipatna. Yes, go ahead.
Yeah. I mean, melphalan is your go-to medication. It's going to, in nearly every case, it's going to work. It's just you have to be able to swallow the complications. And I've seen complications even with melphalan 20. I never go above 20. I always stay at between 15 and 20.
Yeah,
I think there are a couple of things. One of that is that the whether it's pigmented eyes or non-pigmented eyes, we do still see the pigment retinopathy of melphalan. And I think we get to treat a fair share of pigmented eyes as well. And I find that if you do have, if you do shake the eye quite significantly and not after the injection, I usually think that would reduce the chances of pigmentary retinopathy, allowing the drug to disperse a little bit more. And usually the pigmentary retinopathy is at the same quadrant of the injection. So I think perhaps some of the drug is then seeping between the vitreous and retina, and so the pre-retinal space in some way to pool over there or cause some issues locally, and I'm not sure exactly what that is. But I do think that allowing the drug to disperse a little bit more, you'd see a lot less pigmentary retinopathy.
Right. So we have Jesse and Mahesh and Rachna in that order. Jesse?
Good morning, everyone. I agree, and we have done all of this as well at Children's Hospital Los Angeles. I find that the topotecan, the seeds tend to regress more slowly. And so what we have found is that if we are going to go to topotecan, we just have to breathe and sometimes even increase the interval between injections. As Carol mentioned, I think she said 2 months. We tend to sometimes go to 1 month, and slowly the seeds do regress. Thank you.
Mahesh?
Yeah, I usually don't give melphalan and topotecan, but recently there was one child with refractory case where we had to give about 10 micrograms of melphalan we added to it. So this child developed hemorrhagic occlusive retinal vasculitis. So that was quite a disastrous complication which I had. So that's something which we need to, which can rarely happen as well. So, and in addition to whatever Dr. Ashwin mentioned about like shaking the eye, despite the fact that you shake the eye, it is not all the time that like you have a quadratic pigmentary retinopathy, you do get a dispersed pigmentary retinopathy as well, despite the fact that like we try to disperse the medication as well.
Rachna?
So, Dr. Santosh, the 90 micrograms injection that you're giving for topotecan, so you're giving it like the way we do after completion of 6 cycles of intravenous as a second line?
Intravenous or intraarterial, whatever type of chemotherapy, if there is diffuse vitreous seed beyond the cycles of chemotherapy that you would generally give, then you start with topotecan. Diffuse vitreous seeds, I'm giving 90.
Yeah.
Intraretinal subretinal seeds, 90. And vitreous seeds for more than 2 quadrants, 60. Focal and up to 1 quadrant, 30.
Okay. So in these patients which have diffuse vitreous seeds, often they develop PVD, partial vitreous detachment. How do you go on to give further injections in these patients? Do you continue or do you stop or do you modify your technique?
I mean, that really does not matter. How does it matter? If there is PVD, how does it really matter? I mean, of course, there is going to be PVD in every child with retinoblastoma to some degree. I mean, once you've treated the child focally, and if the child were to have initial, say, subretinal fluid, then there is going to be some amount of PVD, which you may recognize sometimes, which you may not recognize. So I don't think it really matters. But let me ask Mahesh. He's a retina specialist as well.
PVD is a very, very different issue as far as retinoblastoma is concerned, having operated on a few of these eyes. So it's never a complete PVD. So the vitreous is differently attached to the calcific residue as well as the tumor inside as such. The rest of the area there can be PVD, but over the tumor residue, the vitreous is quite densely adherent. So I don't think it matters much as far as the intravitreal injection, the way we give or where we give is concerned. So we pick an area where there is less amount of seeds and go inside and give. That's not a major concern.
Have you seen anything like this? An intraretinal cyst and then seeds within it? How would you deal with it? Anyone?
Yeah, I've seen this before. I think this is subretinal seeds.
Okay.
I've seen it grow fast and massively everywhere. And it responded, in the case that I saw recently, it responded to intraarterial chemotherapy plus high dose intravitreal topotecan. In that case, I gave 90. Completely responded.
Right. So this was a patient where there was tractional retinal detachment for which we had to get a pars plana vitrectomy and silicone oil injection done. And then the child developed in vitreous seeds. So is there any possibility of giving intravitreal injections in a child who has developed vitreous seeds after silicone oil injection? The child was lost for follow-up because of COVID and 9 months later came back for follow-up with diffuse subretinal seeds and diffuse vitreous seeds.
It's definitely possible. There's no reason why we cannot give an intravitreal injection. Only thing is like, if you can ask the parents to maintain a supine position, what happens, the oil tends to float and the melphalan or the topotecan, what we give, goes between the oil and the retina and tends to take care of the seeds. So it's quite possible to give. So it doesn't, and it's a kind of not a static procedure. If the child is sitting up, then the oil floats and the melphalan will go down to the inferior part. So that should be okay. If where the seeds are, if it is in the posterior pole, if we can advise the parents, if the child can maintain a supine position as much as possible for about a couple of hours, 2 to 3 hours, that will help.
So Mahesh, you're suggesting that we position the eye. If it's an eye with silicone oil, the silicone oil will float to the top and you position the head to where the seeds are so that the intravitreal injection can get to that location.
That's right, Dr. Shields. That's exactly right. And another option is like what Santosh mentioned. If it is in a quadrant, probably we can consider giving a subtenon injection in addition to the intravitreal injection in that particular quadrant. Otherwise, we just maintain the position of the child so that the oil floats, and where we want the chemotherapy, we keep that in the most dependent position.
In this patient, we preferred intra-arterial chemotherapy and it somehow worked. So we didn't have to deal with giving injection in an eye with silicone oil. But I was worried about the oil coming out and, issues like that.
It doesn't come out like that. It doesn't come out like that. Now, if you're using a 30-gauge needle, 30-gauge needle oil doesn't come out at all. Now, actually, it gives you a tamponade there. So nothing will come out in the area where we give, because you're giving it in the supine position. Where we enter the eye, the seeds or the oil will not come out. So no issue. And you can inject into the oil, you go through the oil and go into the sub-oil space.
Okay, great. Fairuz, you wanted to say something? All right.
Dr. Fairuz, you're muted. Okay.
Yeah, silicone oil filled eyes and intravitreal injection. So during my tenure in China, we all know that, they do vitrectomy and even tumorectomy for retinoblastoma. And most of these cases definitely has silicone filled inside. So these patients used to be referred to me for intravitreal injection. One, because they have undergone a vitrectomy to, prevent any recurrence in those eyes and stuff. So I have done injections of intravitreal topotecan in these patients, but I used to go a little higher dosage because I'm sure we don't have any literature whether, the regular dose, we can take the opinion from the panelist over here, whether we have to go higher dose or even, the normal dose would be good enough if it is a silicone filled eye. So I used to go a little bit higher dose on topotecan in silicone filled eyes whenever it got referred for injection. Dr. Mahesh, any thoughts on that?
I would think a normal dose or actually a lesser dose is adequate, because there is less amount of vitreous fluid for the injection to disperse. So if you position the child in such a way where we want the medication to be, that should be adequate, because the vitreous cavity is filled with oil, so it doesn't disperse. So you can have kind of a focused treatment in the area where you want to see, where you want the medication to work.
Okay, and Dr. Mahesh, how challenging is it to position these babies, like tiny babies, tell them to...
I agree, that's difficult to maintain position. So, and of course, we have the same issue if in case like we are dealing with a child with a retinal detachment. So if it in the posterior pole, it's not an issue. So anyway, post-GA, they are lying supine for some time. If it is inferior, once again, you can tell the parents if they can hold the child up erect, that should be fine. You cannot have the child position them. We cannot have them positioned, but we need to, the parents would have to ensure that if they are able to position them as much as possible.
Thank you.
Yeah, I think we're running out of time, but this is just to show one situation where the child was developing massive recurrent subretinal seeds every visit, and this was managed with intravitreal topotecan. So you can see nice reduction or regression of nothing else was given. So this could be completely attributed to intravitreal topotecan because nothing else was given. No laser was done. Again, a situation where there were massive subretinal seeds. Only other option was to go on to IAC or continue with IVC, where again, intravitreal topotecan has worked beautifully well. So if any of you have seen similar response, Dr. Shields?
Santosh, what dose did you give?
30 here. This was an
30.
old. Yeah.
So, I mean, this is a case that might, in Canada, may have been treated with a topotecan plaque. So we're getting similar results to the topotecan plaque by giving a higher dose in the eye.
Right. So unfortunately, we have to end this discussion here. We are running out of time, and it was a very useful, fruitful 1 hour that we spent. And last couple of years ago, we started panel discussion at 5 p.m. Indian Standard Time, and we went on up to 6:30, and we could still finish group A to C, and C was incomplete. Today, I started the reverse way, group E, and we couldn't even get to 25% of group E cases that I had to show and have you discuss. So anyway, thank you very much. I think we have raised some controversies, which I'm sure will be answered in didactic session that follows. Mritika and Fairuz will take over and run the rest of the session.
Hello, everyone. That was really, I think this time the discussions were quite fruitful rather than raising controversies. We did come to some consensus for a lot of cases. We will move on to the symposium, the main symposium. And I would like to invite Dr. Dan Gombos for his talk on retinoblastoma over the years and what does the future hold. He is the current president of ISO and professor and chief department of section of ophthalmology in the University of Texas MD Anderson Cancer Center, Houston. Over to you, Dr. Don.
Thanks. Can you just confirm that you can hear me?
Yes,
Yes.
Okay, thanks. Okay, so thank you again. This is really an amazing group of speakers, an amazing panel, and I'm so honored to be part of it today. I have a number of slides, so I'm going to try to get through this all during my allotted time. Here are my disclosures. I think we can only look to the future if we review the past, and there is an enormous amount of exciting work that's going on in retinoblastoma. I'm going to touch on some of these, but really the speakers that will follow will enhance and really just go through these points one by one. But if there's one or two highlights that I'd like to make just to start with, is that collaboration and advanced genomics are really going to play a more significant role in our near future. Here's just a slide that demonstrates what we believe are annual cases of retinoblastoma. But in a recent meeting in Africa, we know that we don't fully understand a lot of the epidemiology and incidence in some certain parts of the world. And if there's one project that's going on that's really going to highlight that, is going to be the upcoming World RB project, because I think for the first time, we're going to have a project that will truly try to fully understand across the world through multiple transnational, transcontinental, true live epidemiology, where we stand today in retinoblastoma, and will give us a 3-year follow-up. So that's something in the future that I'm very excited about, and Didi Fabian will be leading that group, and with Andrew Stacy, and we hope that everyone will contribute. We know that the presentation of this disease is critical. Strabismus and leukocoria are the way in which they come to medical attention, and ongoing efforts have been very helpful in getting patients into our hands sooner with better outcomes. And in the past, middle-income countries like Brazil and others have been very effective in telephone card campaigns. The future of this is really the digital platforms, and we are seeing that phone apps are mechanisms where perimedical individuals, nurses, etc., can screen patients. And the future here is truly AI screening. And the day will come where you take a picture and an AI platform will tell you whether you have retinoblastoma or not. And this is coming on very soon. As for clinical diagnosis, I think one thing we know is that over the years, experts and advanced training have led to us becoming much better at making the diagnosis of retinoblastoma than if you look at series from 30s and 40 years ago. There have been many grouping and staging. And I think for the pediatric oncologist, the staging recommended by Chantada et al. Is one that has been very much advocated and actively used. It's sad that while we transitioned away from the Rees-Ellsworth's grouping system, that data that we had from those eyes, historic data, is hard to translate to what we currently use, which is the ABC system. I think we still, by and large, use the ABC system in meetings because it's simple. If Dr. Shields says, I have a group DI, I may not actually see that eye, but I sort of know what she means. And I think we've enhanced that with additional clarification on a subgroup of defining vitreous seeds. We now have a verbiage where we say, oh, I have a big area of dust or clouds, and we've learned that that has histopathologic correlation. We will hear about the HACC-TMN classification, and there's some groups using it. But I just say that, this is a complex system, and it doesn't easily speak when someone says, I have a T2A system. And so I think we're seeing some groups using it, but on a day-to-day discussion group, I think most people are still using the ABC system primarily for its simplicity. Multidisciplinary management is the hallmark of this disease, but I think we've learned through COVID that even if you don't have every single component of a multidisciplinary group, you can use virtual tumor boards. And that is the beauty of virtual telemedicine today. So I hope that, and I anticipate that virtual tumor boards will continue to allow countries with less diverse multidisciplinary care to get that focused area if there are areas within the group that they don't have within their particular center. And Didi Fabian and many other people have enhanced the use of virtual tumor boards in lesser developed countries with quite success. We may no longer give primary external beam radiotherapy, but I can tell you even within the past month, I've had patients with the secondary effects of external beam radiotherapy. And I think we're still going to need long-term data on the true incidence of second malignancies, therapy-induced and other. We're going to hear a lot of talks about the management of retinoblastoma. There are many different ways to give chemotherapy. If someone asked me what was the single most important advance, my opinion would be intravitreal chemotherapy. It wasn't that long ago when we would see eyes with vitreous disease and say those eyes were going to have to be enucleated. And as we saw in the talk earlier today, vitreous seeds are curable, addressable, and now we're fine-tuning it with dosing and agents. But to me, this is the most significant advance in our field. As it relates to treatment, there is some consensus. I think we're all hearing consensus that, advanced unilateral disease in many centers are treated with primary intraarterial chemotherapy. We still may have some discussion about which EI should be enucleated or not, but I think here again, there's more consensus than less. Where we see a lot of disparity is still the bilateral cases. Some centers still advocating for intravenous chemotherapy, others with intraarterial. We'll hear Matt Wilson talk about the potential advantages of intravenous chemotherapy. Collaboration has been truly a significant advance over the past years, significantly through this children's oncology group. And despite some individuals consistently saying you can't get collaboration in a rare disease in North America, that's simply not the case. COG has opened and closed 5 prospective multi-center trials, with perhaps the metastatic one, I think, being to me the most significant, showing that early stage disease is curable. And even in the best of hands, stage 4B disease to the CNS still has very poor prognosis. We're seeing collaborative efforts, not just within North America, but also within our European colleagues. And my hope and vision is that the European cohorts, together with international cohorts and North American cohorts, will continue with prospective multi-center trials, really answering questions that simply cannot be answered in a single institutional center. We know about the WHO initiative, highlighting for the first time retinoblastoma as an important malignancy for pediatric cancers worldwide. We've now developed guidelines for screening, and I think one of the most important aspects of that is an understanding and advocacy that genetic testing should be and is a standard approach. There are newer modalities, some of which include oncolytic adenovirus, and we've heard Carol Shields talk a little bit about the topotecan plaque, which is an alternative approach to getting chemotherapy in the eye. And my last slide is really where I think the future already is in cancer today, and we have to transition to that in retinoblastoma. And that is personalized mutational analysis to direct personalized care for patients. We're already getting some of that data, but I think the question at hand is whether aqueous or blood will be the messenger of providing that DNA information. And my prediction is both will play a role. So in conclusion, the past has been significant, but the future is unyielding. We'll be learning more about the true world epidemiology. Technology will play a significant role, including telemedicine. And the future is patient-specific mutational alterations to direct patient-specific therapy. Thank you.
Thank you, Dr. Gombos. After that overview, we'll move on to our symposium that has been structured in a way that we start with the grouping and the staging, move on to the different types of treatment of retinoblastoma, go on to the histopathology, then the genetics, and finally orbital disease. So now I would like to invite Dr. Ashwin Malapatna, who's the head of retinoblastoma program in the Hospital for Sick Children, Toronto, Canada, for his talk on grouping and staging of retinoblastoma. The discussant for this session is Dr. Swati Kaliki. Unfortunately, she was unable to join us because of she's traveling, but she has sent us her recorded video, which I'll share for Dr. Ashwin's talk. Go ahead.
Sorry, I think your mic cut off. Can I go ahead?
Yes, please.
Okay, sorry. So I think thank you for inviting me to the session, and I think my talk has been made a little bit easy based on the discussions that have happened so far. I think there are many staging systems, and we have to acknowledge that it's brought our knowledge to where we are. But are we really on the same page is my topic, and I'd like to address that a little bit. This is a unilateral retinoblastoma that we can see, and with these photographs, I just wanted to I don't know if I can take a poll, but if somebody wants to attempt in some way to tell us what this would be, you'd need to know how much of the eye is involved if you really want to decide whether it's a group D or a group E, and by which system is the question. Because as we know that some people will call that eye a group D and some people will call that eye a group E. So are we really, again, on the same page in making sure that we understand which disease we're talking about? The ABCDE that I was introduced to in my training days now 15 or 16 years ago, or maybe about that time, was this, which a D would be an eye with diffuse vitreous seeds, and an E would be something that we would consider unsalvageable at that time, at least. But then in our eyes, is that truly an E or is that not? An EI was something that we would tend towards enucleation for treatment, as Dr. Gombos alluded to as well. When we started to present those cases around, it became apparent that there are two different versions of the ABCDE at that time. And one version would call a certain eye a group DI, and another version would call a certain eye an EI. And the differences are here highlighted in red. The most significant difference being the one that has extensive retinoblastoma occupying more than 50% of the globe, which would call an eye an EI. And therefore, the patient we showed you in the previous slides would be considered a group EI at that point, and making those EIs not comparable to others who would call that a DI. So literature that's brought out after that has been confusing. And these are some of those examples of literature in that way. This is an example of a paper that would go on to describe what an EI is, but the definitions have been borrowed from both the systems, so thereby inventing perhaps an additional method of calling an eye an EI or not. And this is a meta-analysis of patients with intraarterial chemotherapy, where they've determined eye salvage according to the groups in percentages, but group A to group E, again, if we're not calling this the same in each center, then perhaps we're reporting different outcomes in these different centers. Is there a significant difference here? We won't know if that difference is because of the way we group these eyes or the way we treat these eyes. And I think it's essential that we come on to the same page at some point. Here is another example. If you actually divide high-risk pathology based on which group they are, you might notice that those that use different definitions have different rates of high-risk pathology in primary enucleations. And because of all of that, there was perhaps an effort to move on to a different system, and a system that at that time was prevalent, but perhaps not at its most logical distribution was the AJCC system, which then went on to be modified to what we think is now more systematic and more logical. And at that point, we really wanted to, one of the big questions there was which group D or EI is associated with high-risk pathology, and therefore we substratified the risk based on what we know at that time. Predicting the prognosis for vision and globe and life was, we looked at all of the parameters that could do that for us, and we decided that the only thing relevant from Rees-Ellsworth classification that could be brought forward was the presence of vitreous seeding, because treatment modalities had changed to a point where the rest of those parameters perhaps didn't make as much of an impact. Both the IRC and the ICRB stage grouping systems or classification systems would give us each parameter that we would then go on to study. And then we looked at a lot of those eyes that were collected in the International RB Classification Survey, and we went on to analyze that before we actually made recommendations for changes in the AJCC system. So AJCC demands that this is an anatomical staging system. In other words, we really need anatomical category differentiations, and I'll tell you what that means as we go forward. And it's in its most simple essence, I think the AJCC system has four stages, and you have to have disease that would progress from one stage to another stage. So the first one is an intraretinal disease, and from that it goes on to occupy the intraocular space, in other words, occupy the vitreous. And an advanced intraocular disease is those eyes that have tumor that is getting ready to leave the eyeball, and extraocular disease is obviously those diseases that have left the eyeball, or that tumor that's left the eyeball. This being the TNM system, there's nodes and lymph nodes and metastasis that also requires staging at the same time. And what was introduced with the retinoblastoma chapter was this stage H1. And stage H1 would go on to mean heritable disease, because that actually was one of the largest predictors of outcome after they survived retinoblastoma as well, but even while they had even the retinoblastoma alone. Each of these stages are divided into sub-stages, and those sub-stages might be modified again with the future of AJCC. But I don't think the main stages will be modified to any extent. In other words, the stage at which the T1s, the T2s, the main groups would likely not change, because that describes the anatomical progression of this disease. And this is just a graphical representation of the same, where T0 in this situation would mean no tumor in the eye. T1A is a small peripheral tumor. T1B is those that are closer to the areas that are responsible, the optic nerve, or closer to the macula. And T2s are that with the retinal detachment, with the T2A being detachment alone and T2B being seeds. And with the current modalities of treatment, the outcome was not found to be significant significant in the future between vitreous seeds and subretinal seeds so much. T3s are those that are largely would be called EIs according to the Murphy classification, And in those, the eyes that are either thusical or have tumor invasion of the choroid, pars plana, ciliary body, lens, or any of the anterior segments of the eye. I think I want to highlight the word invasion because that can be detected in many ways, as Dr. Gombos alluded to, and as was discussed earlier as well. MRI is playing a significant role in detecting that invasion, and we also have UBM for the anterior segment. So I think radiological involvement in the staging system is something that has come with the AJCC, where radiology is a part and parcel of the staging and not a separate entity. We don't rely only on clinical features to tell us which stage this child is in. Therefore, we would like to replace the use of group E with T3 eyes, and I think that would be the recommendation from us going forward, in a way that we're talking about the same type of eye going forward. T4s are those tumors that have left the eye. So T4A is those that are radiologically, they have subtle features that the tumor has left the eye, or T4B is where they've clinically shown obvious features that they have left the eye. N0, N1 is with the lymph node involvements. M0, M1 are those with metastasis or no metastasis, and I won't go into great detail there. But you also have the pathological system, where pathology also goes along with the same sort of staging. And graphically, when you represent that, PT1s are those with tumor in the eye, but not showing any signs of spread outside of the eye. Currently, PT2A is where you have focal choroidal involvement and you have intralaminar optic nerve involvement. And PTB is where you have just isolated cells found in the Schlemm's canal or anteriorly as well. PT3A is where you have massive choroidal invasion. PT3B is retrolaminar optic nerve invasion. And PT4 are those that have signs that tumor has left the eye. So going back to the case example that we started with, this is a group D by IRC and a group E by ICRB. But when you actually go ahead and look at the T1 weighted post-gadolinium MRI, you are seeing a sign over here that this tumor has now left the retina and is now reaching the choroidal space, which is and this correlated post-enucleation in a way to make this now from a CT2BI to actually a CT3BI, which tells you that there's the uveal tissue involved in some way. And sure enough, histopathology was able to confirm that. Now, histopathology may not always be, you may not always have this kind of an obvious 1:1 correlation between radiology and histology. But I think radiology is playing a much larger role now than it was before. So moving on to a system that helps adopt that may be something that's useful. And I've put in a QR code here for a paper that talks about the various technologies and signs and protocols for MRI that would be adopted to help generate images like this. And this is another similar case where this sign over here, or the area of tumor here, was found to have radiological significance before it was found in histopathology. And as Dr. Gombos talked about, Dr. Chavez-Perio's work as well, which would indicate that these tumors that are massive choroidal images right next to where the optic nerve is perhaps more significant than any other type of massive choroidal invasion, and therefore paying special attention to these tumors. So we do also have, thanks to the work of Ankit Tomar, and we do have the percentage survivals of these different stages of diseases. And I'd suggest that you go through Ankit's papers to help us understand really what the odds are in these situations. And one of the things spoken about was neovascular glaucoma and what we would do in that situation. There is a 44% or an odds of 2.3 to have a high risk pathology in those eyes. So I think those should be considered similarly, and those might not always be detected on an MRI. This is an example of us maxing out almost every stage there. So this is a tumor that's spread into the brain. I think the staging systems will help us with that more than the classification system. So this might not, this is an extraocular tumor, therefore not a group E tumor. Group E would be only those that are considered intraocular, because the IARC and ICRB are designed for intraocular tumors. And this is again an example of a case where you'd have one eye that's advanced and the other eye that's not advanced, in a way that this is a T4A, because MRI would show you that that this tumor has started to leave the eye. It may not be clinically apparent, but it is radiologically apparent. And of course, proven by histopathology as well afterwards. And the other eye, of course, went on to get treated. This is a situation where knowing the H stage is important, where the child, the mother was not known to have a retinoblastoma, but is H1. She was unilaterally enucleated, not told about the tumor, but of course, the child developed bilateral retinoblastoma with the same mutation as mom. And I think I will end the talk there by saying that the staging system is really not as confusing as it is. It's a new system. It takes time to get used to, of course, but T1, T2, T3, and T4 are in progression, as we mentioned, and that follows the natural history of the disease. Therefore, it's simple to follow. It obviously better defines those eyes that might have a risk to preserve. So CT3 are those that we would think have safety concerns when we're considering preserving those eyes. This does, in our mind, attempt, at least initially, to combine the IARC and ICRB systems. I think there's still work to be done, and along with Dr. Jesse Berry, I will be talking about changes to this edition and moving on to the 9th version, which will hopefully reconcile a lot more of those differences. None of the major stages, such as these mentioned here, are anticipated to change, and we're considering not deleting anything, but adding things to these systems to give them more values. So again, we're moving away from the familiar but inconsistent group D to group E, and the system that would be a single system that's useful to ophthalmology, oncology, radiology, pathology, and genetics. And again, the QR code for radiologists in a way that they can follow the same protocol, or we can follow a similar protocol all across the world, so we can have a standardized MRI system in some way. Of course, there are other reasons there, like H1, which is not there in any other tumor, and it better refines high-risk pathology by actually grading the high risk. As Dr. Gombos had mentioned, not all high risk is high risk. Oh, sorry, not all high risk is the same, in other words. This sort of brings out that difference. This helps you stratify those things as different disease classifications, even if they are high risk. So I think with that, I'd like to thank all of you for the opportunity. I do have a flight to catch, so I might not stay on to the meeting much longer, but thank you for the opportunity, and I'm happy to answer any questions after this.
Thank you, Dr. Ashwin, for so lucidly describing the AJCC classification. I'll just quickly share Dr. Swati's video so that she has basically presented her views in the context of in context of our country. And so I'll just share that, and then we can move on to the next one. Is my screen visible?
I'm not able to join.
Is that visible?
Yeah.
All
Yes.
right. Just play that.
In the symposium online, but I'm very happy to give my comments via this recording. So if we talk about grouping and staging, now of historic interest, of course, we have the Rees-Ellsworth classification, SN classification, etc. But the two most commonly used groupings are the International Classification of Retinoblastoma by the Philadelphia group, and we have another version by the Los Angeles group. And then with minor modifications are the COG or the Children's Oncology group classification as well. Of these, the two most commonly used or widely used classifications in various publications and also in various clinical practices are the Philadelphia version and the Los Angeles version. Now, the major difference between these two classifications is in group D and group E. While there are very minor differences between the B and C, the major differences are between the D and E. The eyes that would be classified as group E in the Philadelphia classification, most of these eyes would otherwise be classified as group D in the Los Angeles classification. For example, the eyes having a tumor occupying more than 50% of the globe would be classified as group E in the Philadelphia version, while the same eyes, if we have to use the Los Angeles version, they would be classified as group D. And this has majorly caused a lot of confusion in the literature because the classifications have been used by different groups in different ways. And because of this confusion, it is always difficult to compare the results in various studies, and sometimes some of the studies may not specifically mention which classification has been used. So to decipher the globe salvage or the vision salvage rates in group D and E have to be considered very, very cautiously, considering which classification system has been used in these studies. While the COG, it has very minor changes compared to these two classifications, still I believe that the two most commonly used classifications remain the Philadelphia version and the Los Angeles version. Now, when we talk about the staging, the international staging of retinoblastoma, which was proposed by Shantada's group, that I think brings in some uniformity in the staging because there is clear-cut definition of each of these stagings. The other classification or the grouping system or the staging system that tried to bring uniformity is the AJCC classification. Now, AJCC classification is currently in its 8th edition, and it does try to bring in uniformity, but I believe the problem with the AJCC classification is it remains a dynamic method where every few years the classification system undergoes modification. For example, we are soon to get the 9th edition of AJCC classification, which might be slightly different when compared to the 8th edition. And because of these differences with each edition of the AJCC, the historical comparison or the comparison of different studies using the different editions of classifications may remain a challenge. But otherwise, this definitely is a good way to bring in uniformity for the classification of retinoblastoma. So I think these were the comments that I wanted to give about the staging and the grouping. Thank you very much.
All right. I think everybody would like to have a discussion on this, but I will move on to the next speaker simply because a lot of people are traveling, but they have been kind enough and gracious enough to join us for the symposium. So now I would like to invite Dr. Matthew Wilson. He's the director of Hamilton Eye Institute, the University of Tennessee Health Science Center at Memphis. And he'll be talking about whether intravenous chemotherapy is still relevant in retinoblastoma today. And for the discussion, I would like to invite Dr. Amita Mahajan, who's the Senior Consultant Pediatric Hematology and Oncology at Indraprastha Apollo Hospitals and an advisory to CanCAIDS, New Delhi, India.
Good morning. Thank you very much for the invitation to be able to join you today. And I will be speaking on the relevance of intravenous chemotherapy in 2024. So when we look at the indications for intravenous chemotherapy in the treatment of retinoblastoma, there are three major indications. One is the treatment of extraocular metastatic retinoblastoma. The other is adjuvant chemotherapy for high-risk histopathology following enucleation. And the other is as neoadjuvant therapy for the treatment of intraocular retinoblastoma. So as alluded to in our prior talk, the International Retinoblastoma Staging System put together by Shantada and others stratifies disease based on intraocular to extraocular to metastatic disease. And this framework has become the foundation for how we prescribe and treat children with extraocular retinoblastoma. And it was around this, the International Retinoblastoma Staging System, that the Children's Oncology Group, ARAT 321, for the treatment of extraocular metastatic retinoblastoma was developed. And this protocol treated children with stage 2 through stage 4 disease with upfront induction chemotherapy consisting of 4 cycles of incristin, cisplatin, carboplatin, and etoposide. From there, children who had metastatic disease underwent high-dose chemotherapy with autologous stem cell rescue. Radiation was used as consolidation to focal areas of metastasis. And when we look at the data that was generated by ARAT 321 for stage 2 and stage 3 disease, we see that the overall survival rate hovers around 90%, with event-free survival that does drop down over time to approximately 40%. When we look at stage 4A disease, and this is non-CNS metastasis, we see that we're able to achieve an overall survival for roughly 60%, with an event-free survival of approximately 50%. However, the results for the stage 4B disease, those patients with metastatic disease involving the central nervous system, remain dismal, with event-free survival and overall survival well below the 20%. As in our first 2 talks, we saw that adjuvant chemotherapy for high-risk histopathology was discussed. And defining what is high-risk histopathology varies across institutions, continents. If we look at the proceedings of the consensus meeting for the International Retinoblastoma Staging Working Group on Histopathology, the consensus which was arrived at was massive choroidal invasion, pre-laminar optic nerve invasion, laminar optic nerve invasion, and post-laminar optic nerve invasion. No decisive indications were made regarding anterior chamber and trabecular meshwork involvement, iris invasion, ciliary body invasion, emissary canal or scleral invasion. The framework of the consensus guidelines formed the backbone for the COG ARAT 322 protocol, which was adjuvant chemotherapy for high-risk histopathology following enucleation. And within this protocol, as designed, the indications for receiving high-risk, for receiving adjuvant chemotherapy were massive choroidal invasion, any choroidal involvement plus optic nerve touch, and post-laminar optic nerve invasion. And all patients were treated with 6 cycles of carboplatin, vincristine, and etoposide. And the schema for the protocol as outlined was that patients without high-risk histopathology were observed. Those who developed metastatic disease were subsequently treated on other protocols or off protocols. Those with high-risk pathology were treated with the 6 cycles as referenced previously, observed. If metastatic disease developed, then treated off protocol or on other protocols. And as we look at the data from this, there are 2 points that should be taken away. One was that the pathology after undergoing central review, there were reassignments of the pathology after central review. And if we look at the number of events within each area, starting with the unknowns, we see that those unknown, whether they had high-risk pathology or not, based on central review, there were no events in that group. And then with the out high-risk histopathology, those that, and for which adjuvant chemotherapy was not required, we see the fact that there were 5 events in the group that received, no events in the group that received adjuvant chemotherapy. In those that did not receive adjuvant chemotherapy, there were 2 recurrences. And when we look at the group with high-risk histopathology that received adjuvant therapy, the number of events following treatment were 4, with 1 recurrence, 1 death, and 1 recurrence and death. And in those that received no adjuvant chemotherapy for high-risk histopathology, there were no events. And if we look at the overall survival curves per stratum, those patients who did not have high-risk pathology, as expected, overall survival and event-free survival was nearly 100%. And for those with high-risk pathology, there was a slight dip in both event-free and overall free survival, but well above the 90%. And lastly, for all patients, eligible patients with consensus histopathologic review, the overall and event-free survival for both groups approached above 95%. At St. Jude, we do risk-based adjuvant chemotherapy based on the degree of histopathologic features. For those patients who have focal choroidal invasion, pre-laminar optic nerve invasion, or laminar optic nerve invasion, no adjuvant chemotherapy is given. For intermediate risk histopathology, those with anterior chamber involvement, including the trabecular meshwork, ciliary body or iris invasion, massive choroidal invasion alone, post-laminar optic nerve invasion plus any choroidal invasion, are treated with 4 cycles of vincristine, doxorubicin, and cyclophosphamide. And for those with high-risk histopathology, that includes massive choroidal invasion plus post-laminar optic nerve invasion, as well as those patients with scleral invasion. Those patients are treated with 6 cycles of alternating vincristine, doxorubicin, cyclophosphamide with vincristine, carbo, and etoposide. And although we currently rely on histopathology to determine the need for adjuvant chemotherapy, with studies going into circulating tumor DNA, the question becomes, are we going to have better markers to determine the need for those patients who need adjuvant chemotherapy going forward, so that we can minimize associated morbidities related to treatment? So for the indications for intraocular disease, we go back to 1996 to what was then Archives of Ophthalmology and is now JAMA Ophthalmology, with 4 sentinel papers published in the fall of 96, detailing chemoreduction with vincristine, carboplatin, and etoposide, and accompanying them with focal measures. And that laid the groundwork from which we now have developed further methodologies for treating intraocular disease. And There have been both COG studies as well as a series of progressive studies at St. Jude, including those with 2-drug therapy, 3-drug therapy based with topotecan. And all studies have shown that intravenous chemotherapy for the treatment of intraocular retinoblastoma is efficacious. So whether we're using vincristine, carboetoposide, vincristine carbo, a combination of topotecan, vincristine with carbovincristine, we are able to get chemo reduction and consolidate with our focal measures. So the question perhaps, rather than is intravenous chemotherapy still relevant in 2024, is the question, has intra-arterial replaced intravenous chemotherapy in 2024? And I think to answer that question, you have to look at what the age of the patient is. Is the patient under 6 months of age? Is the patient greater than 6 months of age? Is the patient amenable to undergoing intra-arterial based on anatomy and age? And then the question is alluded to in the prior talk and by Dr. Gombos, what are we treating? Are we treating the patient or are we treating the eye? Are we treating unilateral disease or are we treating bilateral disease? And what group of disease, whether it's, LA, Philadelphia, AJCC, what stage of disease are we treating? And what are our desired outcomes? Are we preserving the eye? Are we preserving vision? Or are we attempting to preserve both? And what are the acceptable toxicities? Systemic, short and long term, and ocular, short and long term. And what are the acceptable cost and resource utilizations? And this will differ between high-income countries, middle-income countries, and low-income countries. And as discussed in the prior talk, we know that there are harbingers of high-risk histopathology in D and E eyes and within CT3 eyes. And those harbingers of histopathology, high-risk histopathology, mean that when we focus on the treatment of the eye, we do, to some extent, leave the patient under coverage for any potential micrometastatic disease. So is intravenous chemotherapy for retinoblastoma still relevant in 2024? Answer to that is yes. We still treat metastatic disease. We still have the question of how to treat adjuvant disease. And there are those patients in those resource-challenged areas where IA is not going to be available. So I would like to thank everybody for the invitation to talk today. I wish you all the best. And I will finish here.
Thank you, Dr. Matthew. Dr. Amita, what are your views regarding
So can I share? I've just got a few slides. Would it be possible to share?
Please go ahead. Please go ahead. I just request all the speakers to kindly stick to the time limit, please. Thank you.
So thank you so much. I'm a pediatric oncologist and truly, are my slides visible?
Yes.
Yeah. And it's a true privilege to be here on this elite panel. And Dr. Matt Wilson has very nicely summarized that even today, intravenous chemotherapy and for foreseeable future, it will continue to play a part. And I'm just going to share a few thoughts, from our region, and this may be applicable to other low middle income countries as well as share some of the preliminary data from a collaborative multicentric work that we've just concluded. And as luck would have it, all the four principal investigators are here on this panel today. So we know that, for as pediatric oncologists, this is one disease where we would rather give less than more chemotherapy and not give it at all if it is at all feasible, because one of the key treatment goals in management of RB is to limit both the short and long-term toxicity. And much of our strategies focused on avoiding or at least limiting systemic chemotherapy wherever feasible. Nevertheless, a higher proportion in our setting do need and receive systemic chemotherapy. And some of these indications are really unique to our setting. So one setting that we share, Dr. Wilson discussed this very nicely, that patients who are candidates for upfront nucleation, a proportion of them, and based on literature available in the most recent publication in 23, about 25% of those who go on upfront enucleation will need adjuvant chemotherapy. So this cohort will probably be the same world over. Where we differ is in our proportion of patients with extraocular and metastatic disease. The global RB study group has shown that this proportion is much higher in low-income countries compared to the high-income countries, and the published data from India shows that extraocular RB varies from 9 to 27%. The collaborative effort that I was alluding to, which had 1120 patients with over 1,400 eyes, extraocular disease was seen in 17% and stage 4 disease in 8%. And this is definitely much higher than any data reported from the developed countries. And these patients would merit systemic chemotherapy. Bilateral disease, especially in young children, while intraocular chemotherapy, tandem intraocular therapy could be considered, but it is not really feasible in our country. And so 32% of our patients with bilateral disease, a significant proportion of them, again, would merit systemic chemotherapy. Dr. Rachna Meel alluded to the fact that patients with presumed or confirmed germline mutations, should we consider them as candidates for systemic chemotherapy because it may reduce the subsequent development of trilateral disease. And there's this paper, it's from way back in 2001, but it did show that this may be, this may help us. So, but regardless of this, a significant proportion of patients with bilateral disease will merit systemic therapy. Chemoreductive strategies for where we are trying to achieve ocular salvage in group D and E disease is definitely higher in our, in our sort of setting because of lower acceptability of upfront enucleation, even in patients where we would very strongly recommend it. And we do have a higher proportion of advanced disease. Whether this higher proportion of advanced disease, whether we talk about the extraocular or metastatic disease or higher stages of intraocular disease, it is most likely attributable to delayed recognition, delayed referral, and inadequate access. But there is also an emerging thought that whether more aggressive biology in our setting is responsible. Regardless of that, as you can see in our total cohort of 1120 patients with 1478 eyes from 20 centers collected, enrolled over 3 years, 838 of these had intraocular disease. But of this group D and D, the 795 of over 1,000 eyes had group D and E disease. Children under less than 6 months they are a challenge for centers where intraarterial chemotherapy is done routinely. And in our cohort, about 11%, over 11% of patients were under 6 months of age. They do, so technically making it much more challenging. And almost all of these patients will receive and have received systemic chemotherapy. A unique indication for which we use systemic chemotherapy fairly often in our setting, and it is similar to some other low middle income countries, is to limit abandonment. Even where we realize that enucleation is inevitable, offering it upfront quite often leads to the family opting for alternative therapy or not opting for any therapy and coming back to us with very advanced disease. So it is frequently used in this setting, and this study I think you're all familiar with it, did show that this strategy in settings such as ours may limit abandonment. Of course, continuing it beyond 3 to 6 cycles can, like as we understand the implications of prolonging this therapy for this setting, but nevertheless, it is a reality in our setting. Finally, the feasibility of intra-arterial chemotherapy. On the left is a map, fairly recently mapped, of centers that treat retinoblastoma, specialized centers that treat retinoblastoma in our country that we could map. And 8 of them, at the time of this mapping, were able to offer intra-arterial chemotherapy. So patients would really have to travel quite far. The logistic implications are significant. But this feasibility is not unique to our setting. Dr. Murali just published this paper, and he's on this panel looking at the feasibility in a multi-institutional study as a COG study. I think there were 9 centers in this study. Patients only above 6 months were enrolled, and the feasibility was 67%. So there are challenges with feasibility globally. These are just enhanced in our setting. So just to summarize, in this study that we recently concluded, this was the treatment plan by the treating ocular oncologist and the treating team at the time of enrollment, with over 2/3 patient planned for chemotherapy to begin with. Finally, we expect that as we collect data on what was the actual treatment given, this will rise because a proportion of enucleated patients will merit adjuvant chemotherapy, and some may have not opted, families may not have agreed to upfront enucleation, and that would add up as well. So just coming back to, is intravenous chemotherapy still relevant in retinoblastoma? Dr. Matt Wilson already showed that it is, but in our setting, probably very much more so. Thank you.
Thank you, Dr. Wilson and Dr. Mahajan, for bringing out very relevant points here. It is my great pleasure to invite our next speaker. It's Dr. Carol Shields. She's the Director of Ocular Oncology Services at Wills Eye Hospital, Philadelphia, and a mentor to a lot of us here. And for the discussion, I invite Dr. Mahesh Shanmugam. He is at Shankara Eye Hospital, Bangalore, and one of the most experienced ocular oncologists in India. All right, I'll just share the video if that's okay, Dr. Shields. I'll go ahead with that. And Dr. Shields is available for the discussion. I'll just play the video.
Hello, my name is Carol Shields. I have no financial disclosures. And I'd like to talk to you about retinoblastoma classification. Can it predict chemotherapy outcomes? From the Ocular Oncology Service at Wills Eye Hospital in Philadelphia. So there's an international classification of retinoblastoma groups, A, B, C, D, and E. We use this every day in our practice. Group A is small tumors, and I've highlighted this in yellow. You can see small tumors 3 millimeters or less in size. Group B is bigger than 3 millimeters, or in the macula, or with subretinal fluid. Group C has localized seeds, whether it be subretinal or vitreous seeds, within 3 millimeters from the tumor. Group D has diffuse seeds, vitreous or subretinal, and more than 3 millimeters from the tumor. And Group E is extensive, occupying more than 50% of the globe, often with neovascularization of the iris and sometimes opaque media. So retinoblastoma has a list of management possibilities. Back in the day, we used to treat with enucleation, external beam radiation, or plaque brachytherapy. Now it's all about chemotherapy, but yes, we do use plaque radiotherapy if needed. Current management is all about chemotherapy. It takes a village to manage one case of retinoblastoma, from ocular oncology to pediatric oncology, neurosurgery, interventional radiology, pediatric ophthalmology, and on and on. I'd like to share with you single-center real-world outcomes of intravenous chemotherapy and intra-arterial chemotherapy for retinoblastoma. First, let's talk about intravenous chemotherapy for retinoblastoma. This was introduced in 1994. The first 4 reports were published in 1996 in Archives of Ophthalmology from London, Toronto, Philadelphia, and Los Angeles. And then an editorial was written on this new era of chemotherapy for retinoblastoma. Now, fast forward 29 years of experience. Here you can see intravenous chemotherapy for retinoblastoma before and after with consolidation. Good results. Another before and after, no consolidation in the macular region. Occasionally, we do see recurrences. Here's a tumor before treatment. It shrunk down with treatment, but then we had a macular recurrence occasionally. And here's really advanced retinoblastoma. 1994, we saw this patient, group D retinoblastoma in each eye. And here you can see total retinal detachment with large retinoblastomas, both eyes. And following intravenous chemotherapy, the tumors regressed, the retina settled, and there's a macula in the right eye. This child's now 28 years old with vision of 20/30 and 20/70 and no metastatic disease. But is it really lasting for all patients? So if we fast forward to 20 years, is there still tumor control? Well, we published in BJO 2020, long-term, 20-year, real-world outcomes of intravenous chemotherapy for retinoblastoma in almost 1,000 eyes. And here's what we found. Groups A, B, C, D, and E. At 1 year, we have very good control. A, B, and C, 93% or better control. At 2 years, it maintains. At 3 years, the same. 5 years, about the same. 10 years, about the same. And 20 years, about the same. So what we see at 2 to 3 years is about what we see at 10 to 20 years. So in answer to the question, yes, it is lasting to 20 years. This chemotherapy completely controls retinoblastoma, but there are some caveats. We need intra-arterial chemotherapy or plaque radiotherapy in some cases. About 20% of patients need IAC, and about 20% of patients need plaque radiotherapy at intervals of about 5 or 13 months after the chemotherapy, intravenous chemotherapy. So overall, IAC and plaque radiotherapy are still used, but only if there's recurrence in these cases. Now, do we need intravitreous chemotherapy? Well, not that often. Only about 10% of patients require intravitreous chemotherapy because the systemic chemotherapy controls all vitreous seeds in most cases. So we looked at risk factors for tumor recurrence following primary intravenous chemotherapy, and we found younger patient age at presentation, greater classification of retinoblastoma, closer proximity to the disc, and presence of subretinal seeds were the 4 factors that predicted recurrence. Not very significant, but they did predict recurrence. And most recurrences are found before 3 years. So in answer, yes, intravenous chemotherapy provides good control 20 years and very rare recurrence after 2 to 3 years. Okay, now let's move on to intra-arterial chemotherapy. Intra-arterial chemotherapy was introduced in 2008. We now have 15 years experience. We use 2 full-time neurosurgeons who catheterize the femoral artery up to the ophthalmic artery. They are expert at how they do this treatment, and between you and me, they never pass a case because one false move can lead to an ischemic eye. So here's the route they like to do, up into the carotid, the internal carotid, and then peeking into the ophthalmic artery, not entering into it. They allow the flow of blood to drag the chemotherapy into the eye through the ophthalmic artery. So here we see before and after intraarterial chemotherapy for group C retinoblastoma. No consolidation. We never consolidate any eye after intraarterial chemotherapy. Here's another eye, group D retinoblastoma, exophytic, subretinal fluid. Before and after, you can see dramatic response. Again, no consolidation, no laser, no cryotherapy, and this patient received 3 doses of melphalan. Here's an even more advanced group E in a 3-year-old boy. We talked about enucleation, but the father really wanted eye salvage. So here he is before, here he is after. I am thankful that we did eye salvage with intraarterial chemotherapy, but we also needed intravitreal melphalan and topotecan for 6 cycles to achieve this excellent control. So we published in JAAPOS 2021 intraarterial chemotherapy for retinoblastoma over 1292 infusions. And you can see in that series, group A, B, C, D, and E, we don't give IAC for group A, but for B, C, D, and E, we do. And we have excellent control at 1 year. Still good control at 2 years, and still good control at 5 years, with dropping control for group E. So what we see at 2 years is pretty much what we're going to see at 5 years. Overall globe salvage rate was 76%, with a median of 3 infusions. And as we've become very experienced with this technique, complications are seen in only about 1% per infusion. So if you look at this, solid tumor control in the upper left, comparing children under age 12 months and children over age 12 months, the children under age 12 months do a little better than children over age 2 months, significantly. But if you look at on the right, you're going to see there's no difference per age in subretinal seed control or vitreous seed control, but globe salvage is significantly better in those babies that are 12 months or less in age compared to older children over age 12 months. At 1 year for those under 12 months, at 5 years for those under 1 year of age, it's 92% globe salvage versus only 72% for those over 1 year of age. So is it lasting, intravenous and intraarterial chemotherapy? The answer is yes, both are lasting. So if we look at 20 years, primary intravenous chemotherapy provided complete globe salvage in groups A, B, and C greater than 90% of cases, in D about 70% of cases, and in E about 30% of cases. And primary IAC at 5 years was even more powerful. For groups B and C, 100% globe salvage, D almost 90% globe salvage, and E almost 60% globe salvage, for an overall globe salvage of about 75%. So retinoblastoma, here's our team saving lives and saving sight for a long time. Thank you from the laser-focused retinoblastoma team in Philadelphia.
Thank you so much, Dr. Shields, for the wonderful presentation. I understand that there is connectivity issue because of the geomagnetic storm warning.
Right. The
Dr.
northern
Chan,
lights. We'll blame the northern lights.
the beauty and the beast. Dr. Shanmugam, please go ahead with the discussion, please.
Thank you, Dr. Shields, for a wonderful lecture. So let me share my presentation. So all of us prefer intraarterial chemotherapy, and Dr. Shields has shown that excellent results can be achieved with intraarterial chemotherapy. Let us put intraarterial chemotherapy in an Indian context. So we have been talking about this over the last 4 to 5 years, and in fact, in 2019, there was a commentary which I wrote about intraarterial chemotherapy in Indian Journal of Ophthalmology. And in that, we had mentioned issues of cost. Cost of intravenous chemotherapy in our country can be offered free of cost to the patient, and approximately it costs around 5,000 per cycle in 2019. In contrast, intra-arterial chemotherapy is around 10 times more expensive, to 10 to 20 times more expensive. So we have the stumbling blocks, which was the catheter, which was a considerable cost to the patient. And the number of centers which are performing the treatment were quite less. So we had suggested that if we can increase the number of centers which are performing or offering intra-arterial chemotherapy in our country, the penetration of the treatment, the cost of the treatment can come down. And if governmental intervention can be there, that can also rationalize the cost. And we did have this same webinar about 2 years back, that's in 2022. And we did a small survey where we found that IAC was around only in about 10% of the cases done across the country, IAC was done. Around 90% was intravenous chemotherapy. So the costs were the same. And coming on to 2024, we did another survey, and what we found was the percentage of IAC has increased. So it has increased from some of the centers were not all doing IAC to some centers doing 90% of the cases of like primarily treating the patients with IAC. And around starting from 10% in 2022, we have probably moved on to about 25% of the centers preferring IAC as the initial treatment. Cost still remains a concern. Cost considerably is probably has increased a little bit, costing somewhere around 10 to 20 to 30 times the cost of a single session of IVC. So complications, while across the world people have perfected the art of IAC and the complications have come down, in a small survey which we did amidst people who are doing IAC in our country, we found that like all of them have come across complications, significant vision-threatening complications like ophthalmic artery occlusion, life-threatening complications such as hemiparesis, optic atrophy, choroidal atrophy, vasospasm needing resuscitation, and reversible TIA. So over the years, since 2019 and 2022 to 2024, we have made some progress. There has been some attempts at indigenous development of the catheter. Though there has been an indigenous development of the catheter, the cost is not significantly different from the one which we import from elsewhere. So the cost of IAC still remains a stumbling block. And there has been an increase in the number of institutions performing IAC. More neurosurgeons and interventional radiologists across the country are performing IAC. And even non-governmental organization hospitals as well as government hospitals are performing IAC, thereby increasing the penetration of IAC and probably rationalizing the cost to some extent. And if the government has rationalized the costs, it possibly has not occurred, and the government-sponsored insurance schemes, if they can adopt IAC as one of the treatment options, then we may be able to offer this treatment to many more patients. So to summarize, IAC is still preferred treatment in unilateral retinoblastoma, but then all of us would prefer IAC as the preferred treatment. But then like cost constraints still remain a stumbling block. We have made some progress in the last few years, and probably as a group, we can try lobbying for including IAC in the governmental insurance scheme. Future, probably as we predict that there will be a slow increase in IAC penetration. IVC is still a great treatment, as like Dr. Carol Shields showed, and there have been select situations like this one-eyed child with retinal detachment under retinoblastoma, where this is a recommended retinal detachment where we are forced to intervene. And we usually do this under cover of IVC. So now doing IVC is not a bad treatment, but preferable if we can move on to IAC, particularly in unilateral retinoblastoma patients. Thank you so much for your kind attention.
Thank you, Dr. Shanmugam. In the interest of time, I'll just move on to the next speaker, and we can take the discussions later on if we have some time. So now I'd like to invite Dr. Francis Munier, and he'll be talking about vitreous and anterior segment seeds in retinoblastoma, what's hot in 2024. Dr. Munier is from Jules Koenen Eye Hospital, Switzerland. And for the discussion, I'd like to invite Dr. Bhavna Chawla. She's the professor at Dr. RP Center for Ophthalmic Sciences, AIMS. I'll be sharing Dr. Munier's video again. Thank you. So just bear with me here. All right, is that visible?
Dear friends and colleagues, it's my pleasure and an honor to be part of your meeting, and I would like to thank Santosh for the invitation. So I propose to you to speak about what we know about intra-arterial and intravitreal and intracameral chemotherapy. So to review with you the indications of these two techniques with complete response, to see the limitation, the situation where we have an incomplete response, and we'll also touch the chemotherapy regimen versus melphalan versus topotecan. So we're now going to list the indications for intravitreal, and the first of all, of course, it's an indication in case of primary or secondary vitreous seeding. In case of secondary seeding, it can be spontaneous or iatrogenic. It works for both situations. Now, it is also valid and efficient, fully efficient, in case of retrohyaloidal seeding as seen on these OCT pictures. Now, if a seed happened to implant on the optic nerve, like in this of it, to know in line, sure that there is no seed. Perfect indication for intravitreal, it will work perfectly. Similarly, if the implanted seed is on the retina, provided again that there is no retinal invasion with a demarcation line between the seed anchored on the retina and the retina itself, the intravitreal injection will do the job. Now, there are some other indications with intravitreal chemotherapy, especially when I do it when I plan intraocular surgery, like cataract surgery in selected cases. And also, we do it systematically associated with intracameral chemotherapy to prevent cross-contamination across the anterior hyaloid. Now, if the seed on the retina, for example, has no demarcation line with the retina, like in this case, we have an incomplete response of intravitreal chemotherapy, and you need to give something else like a plaque or a focal treatment, or even sometimes an intraocular chemotherapy. Now, this has been reported to be efficient, but I have to say that only in a limited number of cases, and plus the patient received also concomitant treatments. So for this indication of we need a further validation. Now, since our initial report in 2012 regarding efficacy of intravitreal chemotherapy with melphalan, we had 23 eyes, and seed regression was 100%, but globe salvage of 87% at 22 months. We extended this to 87 eyes few years later, with in collaboration with David Abramson. The seed regression was also close to 100%, with a globe salvage of 93% at 24 months. Others have reported also excellent and similar results, adding topotecan or combining melphalan with topotecan. The problem, as long as you have melphalan in the regimen, you can end up with a potentially sight-threatening complication, and this is the case in grade 4 toxicity, when the toxicity reaches the posterior pole. Now, there was some hope to avoid toxicity with the use of topotecan, and this is a report from India that was very interesting in 17 eyes, with excellent seed regression efficacy and a globe salvage rate of 95% and 24 months. Now, the same group happened to publish this month's follow-up paper with much more eyes, 91 eyes, and reporting a seed regression in 90%. So you see a slightly lower efficacy. It's not close to 100% as melphalan, but at no toxicity, renal toxicity, and with an excellent globe salvage rate at 34 months follow-up. Now, there is a hope to overcome this relative lower efficacy of topotecan compared to melphalan with the use of high-dose topotecan. And so in conclusion, for the intravitreal section, intravitreal melphalan 30 micrograms is safe, efficient, but with variable toxicity. Intravitreal topotecan is safe, slightly less efficient than melphalan with no renal toxicity. And if we can increase the efficacy of topotecan by increasing the dose to 90 or even 100 micrograms without a renal toxicity. Now, let's touch the intracameral chemotherapy. I remember you that we published this technique of bicameral aqueous replacement with a melphalan solution at 20 microgram per ml initially. Now we moved to 30 microgram. So the indications I want to list with you, of course, active primary and secondary seeds, but here it's active in spontaneous seeding, but not iatrogenic. We'll come back to that in a minute. When you have epi-iridyl seeds, implantations or endothelial plaques, as long as you don't have any, you have a demarcation line between the seed and the iris, like in this case, it will be efficient and you have a full response. For the seeds in the angle, also it's efficient, provided on the anti-OCT that your seed anchoring on the trabeculum as a demarcation line and that there is a tumor-free Schlems canal. You have a full response just doing intracameral chemotherapy. Also, in case of Hanover's canal invasion or Petit's canal, but without, I insist, without ciliary invasion, you have a demarcation line here. You have a demarcation line between the seeds and the ciliary body. When the ciliary body is not invaded, you have a full response with the bicameral chemotherapy. Now, I insist on this because it's a limitation of the technique where we have an incomplete response. It means that when you have this type of seeding, interciliary process implantation, you see, intracameral chemotherapy is efficient, is necessary, but not sufficient to get rid of the seeds. You need to combine it with brachytherapy, for example. Here's a case before and after treatment. So since our report, we have published our experience with 11 cases in 2015 with a globe salvage rate of 71% in case of spontaneous seeding in the aqueous versus only 25% in case of iatrogenic seeding in the aqueous at 24 months. We have now extended, the literature also contains other reports. I am not exhaustive here, but the efficacy of ICC alone or with chemoplaque in the case of this group. Now we have extended our report with a 10-year follow-up experience with intracameral chemotherapy, 20 eyes with a seed regression in 100% and a globe salvage rate of 85% at 48 months. So in conclusion, we can say that intracameral melphalan or topotecan at these concentrations are safe and efficient with no site-threatening toxicity. Intracameral melphalan is efficient to control spontaneous non-iatrogenic aqueous seeding, and intracameral topotecan is efficient to control iatrogenic aqueous seeding. ICC must be combined with brachytherapy, for example, in case of intraciliary invasion or interciliary process implantations. And with this, I thank you for your attention and wish you a very nice meeting. Bye-bye. Thank you.
Dr. Bhavna.
Yeah, and can I just share my screen, please? Is it visible?
Yes, yes.
Okay, thank you very much. So, as usual, a very excellent and inspiring talk by Dr. Munier. And I have very few comments here. My job is just to maybe highlight vitreous and anterior segment seeds more from a regional and local point of view. So if you ask me what is hot in 2024, well, Delhi for sure. It's very hot right now. But going on to the main question here about vitreous and anterior chamber seeds in retinoblastoma, we've all seen from the previous talks, and we all know how there has been a paradigm shift towards globe salvage treatments in the last 2 decades: intravenous chemotherapy, intra-arterial chemotherapy, and now intravitreal chemotherapy. And of course, there's no talk on intravitreal chemotherapy that can go on without mentioning the huge contribution of Professor Francis Munier, who's really revolutionized the management of retinoblastoma. And I and all of us over here would definitely agree with what Dr. Dan Gombos said in the beginning of this session, that if there is one single development in the management of retinoblastoma over these years that has been the most significant, then it is intravitreal chemotherapy. And the popularity of its treatment. Hello. Yeah.
The connection is great. So
The slides are not moving, doctor.
the slides
are not showing.
It's showing. You need to put it in PowerPoint show mode, and then it has to move also.
I had put it in PowerPoint. Can I just pause the share and
You can stop the share and do it again, please.
I'll do that. Yeah, I'll do that. Sorry about that. Let me just walk to where I was.
I think intravitreal and intracameral chemotherapy is the most useful tool at present.
Is it better now?
Yes. Could you just put that in the slide share mode?
Oh, actually on my computer it is showing on the slide share, but I don't know why this is.
Doctor, can you do me a favor? Can you just stop for a minute?
Yeah.
Put it in slideshare mode.
Right.
Press Alt Tab on your laptop and come back to the Zoom window.
Alt Tab.
You should be on the Zoom window, and now share the slideshow presentation we have.
I pressed Alt Tab. I came on to the Zoom window, and now
Yeah, now you can click the share button.
Okay.
And select this PowerPoint show slide.
Is it okay now?
Yes, it was. I think you can just make it PowerPoint show. It was there for briefly for 1 second.
This is actually as a slideshow only on my computer.
Are the slides moving forward? Then we can just at least see the slides.
Yeah, at least you can see the slides. So I was talking about Dr. Munir's contribution, and then the popularity of intravitreal chemotherapy can be seen by this global retinoblastoma outcome study, where out of 4043 patients, 8.5.
Dr. No, your slides are not moving forward.
It's not moving forward?
No.
Okay. Maybe I'll have to do it again.
All right.
I'll just do it.
Should I move on to the next speaker till then?
It's just give me one moment. It's right here.
Sure.
I'll try once. If it doesn't, then definitely we'll move on in the interest of time. And then I can just maybe orally speak, if that's okay.
Yeah, that would be better probably. Yeah, I think for
probably,
the discussion.
because there seems to
There
be
is anybody else online and who would wish to give their views on intravitreal as well as intracameral chemotherapy?
So, Maybe I can just speak orally if I'm not
Yes,
able to share my
sure.
slides.
Please go ahead. Yeah. Please go ahead.
1 second.
Dr. Shanmugam, are you there?
Is it visible now?
We can see your presentation, but it's not a slideshow format.
Okay, so I'll just talk about it then. So the reason why intravitreal chemotherapy has become so popular is, first of all, we have a safety enhanced technique in place. So all the concerns that we had about extraocular spread are no longer there using this technique. Then again, it's a targeted therapy, so we're not worried about the systemic issues. Of course, it's inexpensive, like we heard in the previous talks before, how expensive intraarterial chemotherapy is. And then this is one treatment that is, given where the ophthalmologist is in full control. We don't depend upon the pediatric oncologist or the interventional neuroradiologist. So, and then all kinds of vitreous seeds can be, treated with this kind of treatment, whether they are dust or spears or clouds. And of course, most important part is that we get excellent results when we, as we have seen in the talks before. So I'm not sure if you're not able to see my screen, then maybe I can just talk. You're not able to see my screen?
Yes, we can see it, but the slides are not moving forward, so we can just see one slide.
Okay, you can just see one slide. So you can't see the movement of the slides, right? Okay, so no problem. So then I will be skipping this part. So now the two drugs that we have is melphalan and topotecan. Now, as we have seen in the discussions earlier, that topotecan has certain advantages, that it has better bioavailability, fewer injections are required, and it is associated with no retinal toxicity. And this is one thing that is more relevant in Asian eyes with darker pigmentation. So melphalan has been known to have certain side effects, toxicity, even with 30 micrograms. And there are studies to show that a drop of 5 microvolts of the ERG was seen with each injection of 30 micrograms of melphalan. I have some pictures here, but unfortunately you cannot see of the toxicity. So I will just move on with whatever I'm saying. Now, there was this article that was a paper published by Nadelman et al. It was Dr. Abramson's group in British Journal of Ophthalmology 2021, where they tried to answer the question, is intravitreal topotecan toxic to the retinal function? And the study showed that whenever intravitreal topotecan is combined with melphalan, there was a decrease in the ERG amplitude. But when topotecan was given by itself, no such decrease was observed. So they concluded that intravitreal topotecan is less toxic and in fact not toxic to retinal function. And again, the two studies that I wanted to quote from India by Dr. Santosh and Ritika, you yourself, your group, about intravitreal topotecan for vitreous seeds in retinoblastoma, the recently published review of 91 eyes in ophthalmology, talks about how safe and effective intravitreal topotecan is in the treatment of retinoblastoma. And again, there are newer drugs that are under investigation. Some of them are already FDA approved. So the future does look bright for intravitreal chemotherapy in retinoblastoma. Again, intracameral chemotherapy was the other thing that I had to touch upon. And as far as intracameral chemotherapy is concerned, Dr. Munir has already described his bicameral technique. I'll not go into the details. He's also clearly described how we need to differentiate between deposits and infiltrative seeds and treat them differently. Again, the two most commonly used drugs are melphalan as well as topotecan. So to summarize, I would say that, like we all agree, intraocular chemotherapy, if we combine the two terms, intravitreal and intracameral, and use the term intraocular chemotherapy, it has dramatically changed the management of retinoblastoma, and the future looks bright. So thank you very much. Thank you, Dr. Santosh. Thank you, AIOS, and thank you everyone for having me here. I'm really sorry about the technical glitch. And I look forward to the remaining talks. Thank you very much.
Thank you so much. Thank you so much for bringing forth some important points that we should all be aware of. Moving on to the next speaker, we have Dr. Jessie Berry from Children's Hospital, Los Angeles and University of Southern California. She will be talking to us about liquid biopsy in retinoblastoma. And for the discussion, I invite Dr. Rachna Meel from RP Center for Ophthalmic Sciences, Ames, New New Delhi. And Dr. Berry, I'll just share your video, and she's there for discussion following that. All right, I hope that's visible.
Good morning, everyone. I'd like to thank the organizers of the course for inviting me to speak today and for allowing me to record this ahead of time so that I didn't give this talk at 4 a.m. Los Angeles time or wake my young children up on Mother's Day. I'm going to talk today about liquid biopsy and retinoblastoma, how it will benefit us. These are my financial disclosures. So what started with a crazy idea in 2017, or I guess a little bit before, but was first published in 2017, was the idea that the aqueous humor could serve as a liquid biopsy or a surrogate to tumor biopsy for retinoblastoma, and that this would help us overcome the contraindication to biopsy in this disease. This has led to an explosion of research around the world in the last 6 or more years, and from a crazy idea, it is now well established from studies at multiple centers worldwide that the aqueous is a source of cell-free tumor DNA. This is a timeline of some of our aqueous work, which I'm going to briefly touch on today, as well as discuss what I see as the future of the disease. And as I mentioned, this work is being done not just by our center, but at centers across the world, including some early collaborations in India, for which I'm very excited. So what have we learned? Well, first and foremost, we learned that the aqueous has tumor DNA and that that DNA can be used to identify tumor genomic biomarkers that are similar to tumor tissue itself. And this again was from our first work in 2017. We then went on to show in a retrospective analysis, which included 63 samples from 29 eyes, about half of which were saved and half of which were enucleated, that these biomarkers matter. What we found is that when you compare eyes that were saved versus eyes that were not, that the prevalence of 6p gain, which you can see right here, is the difference in that depth of the alteration on chromosome 6 and the P arm between the enucleated eyes in red and the salvaged eyes in blue was significant. And when you looked at globe salvage, the difference in our ability to save these eyes was quite stunning. We also found that tumor fraction, or the percent of tumor DNA, which can be measured basically by the depth of these alterations from the normal, also mattered. And this is a replicative case of that, which shows that there's a very highly altered profile at diagnosis. You can see active disease here. And as injections of chemotherapy went on, the eye did better. You can see that there's less tumor DNA by the normalization of that genomic profile. However, if you look at tumor fraction, you can see that this was increasing with cycles 3, 4, and 5. And in fact, at cycle 6, there's a large molecular recurrence with a spike in tumor fraction that corresponds to what we see clinically. But what's important here is to understand that the aqueous was showing this before, in fact, we were seeing it ourselves. We also understood that in bilateral disease, each eye has independent biomarkers. These tumors form differently. It's like having children, right? You can bring it back to the parent of origin or the RB1 mutation in retinoblastoma. But after that, the alterations that happen are independent to each eye. This is 6p gain, and you can imagine this is the eye that did worse. You can follow this eye longitudinally, showing tumor fraction again, go down, down, down until the eye is cured. And this level of molecular detail cannot be found in the blood. We and other centers have shown that. This was a head-to-head comparison showing that this level of detail is only found in the aqueous humor. That being said, the blood is very important for our understanding of what's going on in the body. This led us to a prospective study and to the development of a CLIA certified laboratory test, which is now available clinically at Children's Hospital Los Angeles. And in this test, we take the samples, we do low pass whole genome sequencing, followed by library hybridization for targeted sequencing for RB1. And this clinical test has allowed us in a clinical setting with a validated test to answer some important questions. So can we use the aqueous for molecular diagnosis in a clinical setting? So we know this is retinoblastoma, and we also know this is retinoblastoma, and we can probably guess which has the worst prognosis here just based on the level of disease. But what about these patients? Is everyone in the room entirely sure this is retinoblastoma? And which eye here has a better prognosis? The aqueous can help guide us. And what about this? These are pictures. Thank you, Dr. Kaliki, for sharing these with me. Is this eye retinoblastoma? There is some calcification, but when you have loss of view, in the past, sometimes these eyes would come out. We now have an option to use a clinical test to give us information about whether there's tumor activity in the eye so that we can avoid this. These are some representative results from, again, our clinical testing. This is a bilateral child, 1-year-old male. You can see the difference in tumor fraction here, and also the difference in these specific biomarkers shown in the blue arrows. These are distinct profiles with distinct primary tumors in each eye. Because we know that 6P matters, at least in our hands, both retrospectively and prospectively in a multi-center way, 6P does seem to matter. We can use the aqueous to understand that we really need to follow these eyes more closely. And this is a 6P eye that had a very late recurrence 2 years after treatment. This was a patient who was picked up in clinic. They had been moved to clinic at that time. And we found that regardless of whether the patient is being treated with intraarterial chemotherapy or systemic chemotherapy, these eyes still do have a higher risk of recurrence. And again, this is our recent prospective analysis here. This is another patient, a retinoblastoma of the right eye, a 1-year-old female. You can see that this is a pretty advanced eye clinically. You can't see any normal intraocular structures. There, in fact, is not high-level 6P gain here. And at the end of therapy, you can see that this eye did quite well with a normalized genomic profile. This is another patient, bilateral patient. You can see very altered but distinct profiles in the right and the left eye at diagnosis. As we all know, sometimes seeding, the seeds are actually dead, but are present clinically. I had injected both of these eyes for seeding. The left eye had more persistent seeds than the right. They had not all calcified. And so at injection number 6, we took aqueous to see how the eyes were doing. And in fact, you can see that the right eye was stable. There was no need for further injections, but these seeds in the left eye, unfortunately, as they looked clinically active, were in fact clinically active. And so injections continued. We can also use the aqueous to identify active disease when we cannot see clinically. This is a patient who had vitreous hemorrhage. They were actually 5 years out of treatment, and so it was not clear after that much time, was the retinoblastoma active? You say, okay, I'd like to see an ultrasound. Well, the calcified mass actually measured the same as it had before. There was some changes here. Is that hemorrhage? Is it active tumor? Without a view, that can be hard to see. This is the genomic profile, clearly altered. Based on this, we decided to proceed with enucleation, and pathology confirmed a very large intraocular recurrence. Can we also use the aqueous as a negative test? Can we use it to rule out retinoblastoma in the setting of Coates disease or persistent fetal vasculature with a calcified mass? And of course, here the answer is also yes. This is another real-world representative result. This patient was referred for bilateral retinoblastoma, a 1-year-old female. You can see the right eye, poor view, large mass with internal calcification, but the profile was not consistent with retinoblastoma or another malignant process. And the same here in the left eye, which gave us a clue, of course, that this is bilateral fever. We can also use the aqueous to detect retinoblastoma that's driven by MYC-N. That's been published by our center and others, and you can see the spike of MYC-N amplification here, both in patients that have RB1 loss and those that do not. So far, our results, we have 40 patients that have been tested on this new validated clinical platform. We've had 3 technical artifacts, meaning too little DNA to test. So our feasibility so far is 93%. And for diagnosing retinoblastoma, so far we are at 100%. I hope that in the future, this will lead to biomarker-driven trials, and this is how we can imagine that the aqueous will help us. You can do a staging EUA, take blood and aqueous, and consider that maybe if 6P or MYC-N amplification is absent, you could lower the number of drugs and or the number of cycles you give, versus if 6P gain is present, maybe you would give full 3-drug IAC for multiple cycles, and then you could follow the aqueous in order to ensure that the patient you can similar trial where you're looking at intravitreal chemotherapy, and again, on treatment, you are following the patient until they go negative for tumor fraction, at which point you end therapy. If the tumor fraction remains high, you would continue therapy. This is another way we can personalize our treatment of intraocular retinoblastoma now in the real day by using this clinically validated test. So in 2024, what is the role of a liquid biopsy? Well, for me, we can do diagnosis, prognosis. It is eye specific, so you get information about both eyes, and we can objectively monitor treatment response with a clinically validated test. I'd like to acknowledge our patients and families, and of course, all of our collaborators. Thank you so much for having me be here today.
Thank you so much for sharing these exciting possibilities and application of liquid biopsy for retinoblastoma. Dr. Rachna, please, you can take the discussion ahead.
I'll take on the discussion from here. Thank you, Mritika. Can I share my slides?
Yeah. Yes, please.
Yeah, so is it visible?
Yes.
Okay. So at the outset, I would like to thank Dr. Jessie again for the elaborate and insightful talk on this topic and this new exciting and should I say very hot topic in retinoblastoma diagnostics. And although
Dr. Rachna, sorry to interrupt. Can you please make it in the full screen mode slide share, please?
Sure.
Thank you.
Is that fine now?
Clear, absolutely. Thank you.
Okay. And I was saying hot new topic in retinoblastoma diagnostics. And although the team has been working on it for last 6 years, but I would say it is still, this technique is still in its infancy because it is a long way to go in retinoblastoma management. And so I congratulate you on your discovery, and it's already paving way forward in making retinoblastoma management personalized. And when I say personalized or customized, it not only means customized to the patient, but to the eye of the patient. And I hope in the future, even to the tumor that we are treating within the eye and not just the eye. So let me just summarize what Dr. Jessie has already spoken about in her presentation. Just for the audience, once again, since this is a relatively new topic, liquid biopsy in retinoblastoma. So aqueous, what liquid biopsy means now is that we can harvest aqueous humor from eyes of retinoblastoma patients that's harboring the tumor, and it will give us cell-free tumor-derived DNA. Now, up till now, up till 6 years back, the only source of tumor-derived DNA was the enucleated eye or the blood of the patient. But now suddenly we have this sampling method where we get an access to tumor DNA through aqueous. And why this is so exciting is that because now we have a possibility, the chance of having to study, being able to study all kinds of molecular mechanisms that are deriving tumor dynamics in retinoblastoma. There is no limit to studying all these and analyzing them. And as Dr. Jessie said, that this liquid biopsy is much better than getting the same from blood. And the reason for that is we are not only looking at the first hit mutations, that's the germline mutations, but we also now have access to the somatic second line mutations that are happening in the tumors individually, and that differ from tumor to tumor. So if all of us can recall, we have seen so many patients with bilateral retinoblastomas or even multifocal tumors within the same eye responding very differently to the same treatment. And the reason for this is that all of them are harboring different somatic mutations, even though they may have the same germline mutation. In addition to this, there are other epigenetic mechanisms and amplifications, other molecular mechanisms which are hard to study from blood. So it is superior to blood. And so this is the first time that we have an opportunity of creating this library of all the molecular events, which will help us in the long run to categorize tumor treatment outcomes based on the molecular mechanisms that are deriving it. So this is a huge landmark in history of retinoblastoma management. And Dr. Jessie's team is already working on it with the multicentric trial that started, I think, in 2023. I'm supposed to be covering the regional implications of this. So having said that, we did...
Dr. Rachna, your slides are not moving. We are able...
Okay. Is it?
Now we are on the original article slide. Yes.
Yes. Fine. So we'll start from here. So we did a small study at our center in a limited number of patients just to see if we could replicate what Dr. Jessie's team has been doing now for a long time. And we did it in 26 eyes, 20 eyes that were due to undergo enucleation. Now, I hope you can see the slides now. And six eyes that underwent intravitreal chemotherapy. We were able to isolate DNA. The mean concentration of DNA was higher in eyes that underwent enucleation compared to that of the eyes that underwent intravitreal chemotherapy. But when it came to genomic sequencing, we were able to do it only for 4 patients. Only for 4 patients, 2 in aqueous and 4 in the tumor tissue, where in 2 patients we could see that the aqueous humor DNA profile was similar to that of the tumor. So limitation, I must say, funding and cost is a huge limitation in our part of the world. I work in Apex Eye Care Center, which is government run and has research and teaching also. And we see roughly around 250 patients in a year of retinoblastoma, and less than 1% of these patients are actually maybe able to afford conventional treatment, leave alone the high-end targeted treatment. So although the technique is being validated in the rest of the world, but the cost of the procedure in our part of the world, the developing world, is high. So the applications, I'm sure, are going to be different. So what I feel, the limited application that we can put of liquid biopsy in our country, or for that matter, the developing world, are in cases of diagnostic dilemma. We have a lot of these PHPV cases, which have small specks of calcification. We are really not sure if it is retinoblastoma. And usually we keep them on a follow-up of a year or so with the repeated imaging to see if there's any change if the parents are not willing for enucleation. So I think in those cases, a single liquid biopsy may help us to make one-time decision on what has to be done with these patients. Also in advanced intraocular retinoblastoma, which is the most common form of manifestation in unilateral retinoblastoma, we have to decide between a conservative management compared to enucleation. And believe me, it is a very difficult decision to make, especially because our patients are non-affording patients. For them, the cost of treatment is not only one factor. Even coming and visiting the hospital every time for EUAs, stay, transport, everything is difficult to be managed. So the decision of enucleation versus conservative treatment is a huge decision for every patient. So here, I think liquid biopsy could be a great help if it could tell us, if that eye is likely to be salvaged with conservative treatment, or we should go ahead with enucleation in that particular case. Then, of course, we have cases with fish flesh regression after completion of 6 cycles of intravenous chemotherapy. And we have done on focal treatments and everything, but the tumor still stays the same. So in these cases, whether we should go ahead and treat it further, how often we should follow it up, I think these are some questions that can be answered by liquid biopsy in these cases. So I think that was my regional perspective on how liquid biopsy could be put to limited use in the developing world and in our country. And I would also want some comments from Dr. Jesse on 1 or 2 questions that I had, if time permits. Yeah. Yeah. So, hello, Dr. Jesse. And in your presentation, you've said that even before the clinical recurrence, you could record on the genomic profile the disturbances, and you were able to predict that the tumor is likely to come back. So, in patients who on the initial liquid biopsy show a 6p gain and you're suspecting high recurrence, at this point of time, would you be able to recommend how often we should be doing liquid biopsy in these cases, if at all we should be doing, and how frequently?
That's a great question, and thank you for your great contribution. I was so excited to see the paper from India hit my pub crawler, and so kudos to you and the whole team there. So we do use the aqueous to help us guide care in these recurrent settings. So if there is a recurrence in the eye, of course, we take aqueous at that time so that we know the tumor fraction and the genomic alterations. We can compare that to what we had seen at diagnosis, and we are finding that sometimes at the time of recurrence, the alterations are slightly different. We've seen some 19q changes as well as those in chromosome 7. As you mentioned, in the future, this will help us understand the molecular mechanisms that may be driving recurrence in these eyes. In general, we're taking the aqueous during seeding. at the time of a recurrence, as I mentioned. And then we also do a negative test, which means that 6 months after all treatment is done, we take another sample. And at that time, we expect to have a normal genomically clean sample. If we're seeing something there, it's concerning. As I showed in the talk with the patients that I had given 6 injections with, that's another time where a tumor fraction check can be helpful. We all know that sometimes seeds still look active and we can see them clinically, but they regress later in time and are in fact dead. And so that was a nice example of 2 eyes that still had, clinically active seeds, one of which was molecularly active, suggesting that in fact the tumor was alive and one of which was not. So in my hands, I would say every time you do an injection, if you are otherwise going to take aqueous, it's reasonable to check it. And then otherwise, if there is a recurrence, to guide therapy thereafter. And again, as I mentioned, finally, if possible, a 6-month end of treatment check to make sure that molecularly the eye is responding as you would expect it to based on your clinical findings.
Thank you. Thank you so much.
Thank you so much. I'll just move on to the next speaker for now.
Thank you, Ritika.
Thank you, Dr. Raj. Thank you, Dr. Jesse. All right. Now I'll invite Dr. Ralph Fiegel to talk on histopathology and how it guides in the management of retinoblastoma. Dr. Ralph Fiegel is the Director of Department of Pathology at Wills Eye Hospital. Over to you, Dr. Eagle.
Yeah, I'd like to thank you and Dr. Hanovar for allowing me to participate in this excellent program. We're going to show a video. Can you see my screen?
Slowly.
I have no financial relationship.
It's not visible. Yeah, it's there.
Let's review a little bit of histopathology. Retinoblastoma is a small blue cell tumor composed of poorly differentiated neuroblastic cells with scanty cytoplasm, apoptosis, and numerous mitotic figures. The tumor cells undergo necrosis when they extend 90 to 110 microns from a vessel of retinal differentiation, evident as 2 types of rosettes and florets or photoreceptor differentiation. Homer right rosettes represent neuroblastic differentiation. They lack a lumen and have a central tangle of neurofilaments. They were named after James Homer Wright. Flexner-Wintersteiner rosettes represent early retinal differentiation. They have a central lumen that corresponds to the subretinal space, and they were named after 2 people, Simon Flexner and Hugo Wintersteiner. Photoreceptor differentiation occurs in a benign variant of retinoblastoma called retinocytoma. The florets are composed of bundles of neoplastic photoreceptors, typically inner segments, aligned along a segment of external limiting membrane. Although in many cases the diagnosis of retinoblastoma is evident on clinical examination, histopathology can confirm the diagnosis in unusual cases. For example, this 11-year-old girl initially was thought to have granulomatous uveitis. Fine needle aspiration biopsy disclosed a small blue cell tumor. Her eye was enucleated, and histopathology disclosed a poorly differentiated retinoblastoma with massive anterior segment involvement. This 22-year-old woman developed visual loss and a mass in her anterior chamber angle. She initially was thought to have a uveal melanoma based on ultrasonography. Fine needle aspiration biopsy disclosed a small blue cell tumor consistent with retinoblastoma. She was treated with intravenous chemotherapy and responded well, but was lost to follow-up for 23 months. Her blind, painful eye contained a large retinoblastoma with massive uveal involvement. Characteristic histopathology is shown here. Histopathology identifies high-risk features that are an indication for adjuvant chemotherapy in most centers. Retrolaminar optic nerve invasion and massive posterior uveal invasion were the main indications for adjuvant chemotherapy in the Children's Oncology Group Histopathology Chemotherapy Study. Retrolaminar invasion of the optic nerve is an indication for adjuvant chemotherapy at most centers. A tumor behind the lamina cribrosa is outside the eye. Massive uveal invasion has been defined as greater than 3 millimeters in maximal diameter or as full thickness choroidal invasion. This example of choroidal invasion qualifies as massive because it's greater than 3 millimeters in diameter. 16% of the eyes in the Children's Oncology Group study had retrolaminar optic nerve invasion, and 12.5% had massive uveal invasion. The poorest outcome occurred in patients who had concomitant massive peripapillary choroidal invasion and 1.5 millimeters or greater of retrolaminar optic nerve invasion. 3 patients with these findings died despite receiving adjuvant chemotherapy. Such patients may require more intense chemotherapy. This case in the COG study from our laboratory in the Wills Eye Hospital changed the COG study protocol and the standard procedure for gross dissection of eyes with retinoblastoma. In the original COG protocol, only the PO section was submitted. There were no high-risk features in the PO section, and the patient did not receive chemotherapy. Unfortunately, the patient developed distant metastases several months later. Histopathology of the culottes disclosed an area of uveal invasion greater than 3 millimeters that had not been detected on gross examination. The COG protocol was changed. In addition, the protocol for dissection and submission of eyes with retinoblastoma now requires submission of both red love culottes in addition to the PO segment and a transverse section of the optic nerve that includes the surgical margin. This diagram from Dr. Hans Grossnicklas emphasizes that the entire eye should be submitted. In certain cases, histopathology can provide clues to tumor genetics. Although mutations in the retinoblastoma gene are responsible for initiating most cases of retinoblastoma, RB1 mutations are not found in approximately 2% of patients who have unilateral tumors and a negative family history for retinoblastoma. These tumors are called RB1++ retinoblastomas. RB1++ retinoblastomas are poorly differentiated. They behave aggressively and are diagnosed at a very early age. They always are unilateral and sporadic, and siblings are not at risk. They also have unusual cytologic features. They are composed of undifferentiated cells with large, prominent, round or oval nuclei that have multiple nucleoli. Apoptosis is common. There is little calcification, and Flexner-Winterstein rosettes, which typically are common in tumors enucleated from very young infants, are absent. This photomicrograph shows the characteristic round or oval nuclei with prominent nucleoli. RB1++ tumors appear to be driven by amplification of the MYCN oncogene. The nuclei of the tumor cells in RB1++ tumors are immunoreactive for RB1 protein, compared to the nuclei of typical RB1-— tumors, which do not stain. The retinoblastoma in this 26-month-old girl recurred rapidly after intraarterial chemotherapy. Microscopic examination revealed nuclei with nucleoli in the tumor cells that raised suspicion for an RB++ tumor. A genetic test on blood was negative for an RB1 mutation, and the nuclei of the tumor cells expressed RB1 protein consistent with an RB1++ tumor. In recent years, we actually have less histopathology to review, reflecting the efficacy of eye-sparing treatments like intraarterial chemotherapy. Last year, our laboratory only accessioned 11 cases of retinoblastoma. Many of the eyes that we do receive have undergone prior therapy, and many of them contain no viable tumor. Dr. Jesse Burry has shown that aqueous humor may serve as a surrogate biopsy for retinoblastoma when tumor tissue is not available. She was able to isolate cell-free DNA from retinoblastoma from samples of aqueous humor. The results suggest that aqueous humor can serve as a surrogate tumor biopsy when RB tumor tissue is not available. This will allow for analysis of tumor-derived DNA in RB eyes undergoing salvage therapy that have not been enucleated. In the future, it may allow clinicians to diagnose retinoblastoma in situations when the diagnosis is unclear. It also may help to determine whether certain chromosomal abnormalities or mutations in the RB1 gene correlate with prognosis or a response to therapy. She has shown that gain of chromosome 6p detected in DNA in the aqueous humor was associated with a 10-fold increased odds for nucleation. We may have even less histopathology to review in the future. Thank you for your attention.
Thank you, Dr. Ralph. Thank you very much for that talk. I'm going to invite the next speaker now. It's Dr. Murli Chintagumpalla, and he'll be talking about orbital and metastatic retinoblastoma, how we are doing in 2024. Dr. Murli is the Clinical Director of Brain Tumor Program and Co-Director of the Retinoblastoma Program in the Children's Hospital, Houston, Texas.
Let me share the screen. If just give me a minute.
Sure.
Can you see my screen?
Yes, we can.
Good evening. Thank you very much for allowing me to participate in this conference. Wonderful talks. I was happy to hear them. And it's early Sunday here, so happy Mother's Day to everybody, to all the mothers. So the topic today is orbital and metastatic retinoblastoma. How are we doing in 2024? Some of this has already been covered by several speakers, but I will go through some things that may be of some interest to you. First of all, I just wanted to point out, we always talk about metastatic disease, but what actually happens when you don't treat patients with retinoblastoma? Clearly, we warn the families that, they'll all eventually die and so on and so forth. But I don't think we actually captured the data and published it. But I did come across this one article recently in Cancer's 2021. This is from China. It's a 3-author article, and the senior author is Brenda Galli. So what they did was they looked at 29 centers and retrospectively analyzed patients with retinoblastoma. And more than 3,000 of them, 44 of these patients did not undergo any therapy. After the diagnosis, they said they didn't want to do anything else. It's very interesting to note that the median time from intraocular disease to orbital disease is about 14 months, 13.7 months actually to be precise. And from intraocular disease to CNS metastatic disease is about 14 months, and to systemic metastatic disease, it's about 23 months. So clearly, if you look at the data of those 44 patients, within 24 months, within 2 years, most of them die, and definitely by 48 months, all of them are dead. So it's important for the families to know the importance of extraocular disease and what disaster it wrought. The staging for extraocular disease, again, has been mentioned several times during this session by Matt Wilson earlier. So this is the staging system that we looked at when we devised a protocol for Children's Oncology Group. The issue was, how do we actually proceed with designing a protocol where the incidence of extraocular disease is rare in Western countries, especially in the United States? So we decided to involve several institutions in Argentina, Brazil, and Egypt for this study. So we used this staging system, which is, everybody here is familiar with this. Guillermo published this much earlier. So we grouped them to 3 groups, stages 2 and 3, which would indicate orbital disease with or without regional nodes, and microscopic disease, which is basically cut end margin being positive after enucleation. And stage 4A is distant mets, systemic mets. Stage 4B is CNS mets. So what we decided to do was to use 4 cycles of induction chemotherapy, a fairly intensive chemotherapy, consisting of, we'll go through the chemotherapy regimen in a minute. During this process, for regional disease, we would just do 4 cycles of chemotherapy and then followed by radiation therapy to the sites. However, if it's 4B disease or 4A disease, we harvested stem cells after the first couple of cycles of chemotherapy. And at the end of induction, we subjected them to an autologous bone marrow transplant, especially for 4A and 4B. And radiation therapy was dependent upon the response that we got from the above mentioned therapies. Chemotherapy was fairly intensive. If you look at the doses of children who received chemotherapy more than 3 years of age, the cyclophosphamide dose was 2 grams per meter squared per day times 2, which is a pretty hefty dose. And the cisplatin dose was 105 milligram per meter squared per day. Again, that's a pretty strong dose, which we usually use for older kids for osteosarcoma. Nevertheless, that's the chemotherapy regimen that we recommended for 4 cycles during the induction phase. And those are the 4 cycles that patients with stage 2 and 3 received, and nothing else. But if you consider stage 4A and 4B in the table at the bottom, all of them received autologous stem cell transplant, with the preparative regimen being carboplatin, thiotepa, and etoposide. Again, the carboplatin dose was 500 milligrams per meter squared given every day for 3 days. So surprisingly, we did enroll 60 patients of metastatic disease, which is quite a big number considering the fact that we don't see many within the United States. Again, surprising, out of these 60, a little over 40 of these patients came from the United States and North America in general, which was very surprising to us. And the remainder, of course, majority were from Argentina, 1 from Brazil, and several others from Egypt. If you look at the patient distribution, stages 2 and 3 with regional disease, we had 21 patients enrolled. Stage 4A with systemic mets, non-CNS, 18, and stage 4B with CNS mets, 21. A couple of patients were ineligible for the regional disease and 1 for stage 4B disease. There was some issue with enrolling them before getting consent and so on. But anyway, nevertheless, the number of patients who could be analyzed for data were 19 for regional disease, 18 for stage 4A, and 20 for stage 4B. Small numbers, but when the outcome is like this, these become statistically significant. As was shown previously by Matt, for stages 2 and 3, the outcome, the 3-year event-free survival and overall survival was 88%. For stage 4A, it was 77%, which is still very good. Of course, for stage 4B, which is CNS mets, it was dismal. It was only about 14% event-free survival. So this is a subgroup of patients that we really have to think about what to do for them. Unfortunately, many of them are young, and the use of craniospinal radiation, which we often do for infants with brain tumors, for example, we really cannot use it in retinoblastoma because of the young age. And craniospinal radiation therapy may be a key factor that may play a role in cure. The other issue is, going forward, if we were to do any studies on any of these patients, the issue will become numbers. And I'm particularly interested in the percentages shown by Amita Trehan on the quarter of the patients that were enrolled in INPOG retinoblastoma study had extraocular disease. I think that's an interesting point to note. If you can do randomized studies, maybe that's a place to do randomized studies. For example, the regional disease where you have close to 90% cure rate at 3 years, maybe you can substitute cisplatin with carboplatin, or even reduce the cyclophosphamide dose and do a randomized study so that you can reduce the long-term toxicities. But stages 4B, it would still be a challenge, but at least you would have the numbers to tweak the treatment and see what's beneficial for these patients. An interesting point to be made, when they looked at pure pineoblastomas, which are parenchymal tumors that affect the pineal gland, like pineoblastoma in infants and older children, by doing methylation profiling, they identified a particular subset which has RB1 alteration, as you can see here, loss of function. Out of 24 patients who fell into this category with RB1 alteration, 6 of them had retinoblastoma. So there is some relationship between pineoblastoma and retinoblastoma. The pineoblastomas can occur independent of retinoblastoma, obviously, but it's interesting to note that about a significant proportion of them have RB1 alterations without involving the eyes. This is the feature that several speakers have talked about. When we did the ARED 0332 study, which is histopathologic features and the role of adjuvant chemotherapy when high-risk features are present, out of 330 eligible patients, only 3 of them had this particular histopathologic features, which is peripapillary massive choroidal invasion, which you can see, which is greater than 3 millimeters, and post-laminar optic nerve invasion. All these 3 patients died, in spite of adjuvant chemotherapy. So the question is what to do. How do you classify this in the context of extraocular disease? And that is something we probably need to look at in the future. But given the rarity of the disease, it's difficult to make a sweeping statement as to how exactly these should be treated. We did come across 1 or 2 of these patients in our practice recently, and we treat them with the 4 induction cycles that we did for ARED 0321. The follow-up is still too early to know what exactly ensues, but I think that's a reasonable approach to be a little bit more intensive with chemotherapy, especially when you have peripapillary choroid involvement with post-laminar optic nerve involvement. So where do we go from here? We see that intensive multimodality treatment is highly effective for patients with stage 2 and 3 and stage 4A retinoblastoma, especially when you throw in autologous stem cell transplantation. However, for CNS involvement, we need effective therapy and the numbers to do any sort of trial. So I think India might be a good place to look at this, but again, intensive therapies in a group-wide situation may be difficult, but that's something I would be interested to know how exactly it can be approached in INPOG, which is basically a pediatric oncology group in India. And role of circulating tumor DNA. Clearly, this is making a big presence right now, not only at the time of diagnosis for surveillance, and what do you do when you see circulating tumor DNA make its presence known after therapy is completed? Would you treat this as metastatic disease? And if so, how exactly would you address it? What sort of treatment would you pursue in a patient who has only biological feature of a recurrence? So those are all what I should say are thoughts for the future, and we need to get together to see how to address them. Thank you.
Thank you, Dr. Murli. On that note, for a quick discussion, we have Dr. Feroz with us from Horo Specialty Eye Care, Bangalore. She is also the Congress President for this year's ISO 2024. Dr. Feroz, over to you.
Thank you, Mritika. Dr. Murli, excellent presentation, a lot of insights from your experience, and thanks to Dr. Santosh and AIOS for having me here. Mritika, special thanks for you for navigating the entire session here because I'm at work. I'm going to share a slide over here, share my screen regarding our experience and, regarding orbital retinoblastoma. So, I hope my slide is visible over here. So this is a few slides on the Indian perspective, Dr. Murli, and you already spoke about the COG protocol. So what we follow in orbital retinoblastoma is not exactly the COG protocol, something which is slightly different. Before I go on to the protocol, I mean, being a retinoblastoma week, I'm sure we have a lot of audience, delegates, general ophthalmologists and specialists working here. I would just want to raise a little bit of awareness regarding the presentation that we see and the challenges that we see in these advanced cases here. Few cases just, to highlight how these children present. So this was a patient who was referred for further management post-enucleation elsewhere. So he gives a history of intraocular surgeries, an AC tap, and a vitrectomy. And the mother was carrying a histopathology report with her, which stated that it is retinoblastoma, there is choroidal invasion, anterior chamber invasion. In fact, a pediatric oncologist referred this case to me for opinion, how to go further ahead. So when the mother said that there was intraocular surgeries done in this child, and I was kind of worried, and I asked her, "Do you have any pictures, before the child underwent enucleation?" And I was like just struggling to get all the documents in place, although they carried a histopathology, report with them. And I managed to get this image of this child prior to enucleation. So clinically, it is so evident that there is extraocular extension over here with a previous history of intraocular surgeries. And from a histopathology which carried risk factors, of course, where we would have given this child adjuvant chemotherapy as per the protocol, 6 cycles, and not thought about an extraocular extension which existed initially, and not giving appropriate management, this child would have definitely recurred with a secondary or orbital retinoblastoma. So what we did was we went ahead giving intensive multimodal treatment protocol, which I'm going to take you through later, and orbital radiotherapy, and this was how the child looked like after getting the customized ocular prosthesis. Now, we do have various other challenges in this part of the world where, parents, where they do have option of alternate therapy, traditional medicine. They defer chemotherapy. And this was a child with bilateral retinoblastoma, where traditional medicine was sorted. The other eye had a very small tumor, and this eye, the left eye, progressed. When they had initial response with few cycles of chemotherapy, they just disappeared to go for traditional medicine. And these are the social beliefs that we have as a challenge in our part of the world. And this was an older child who presented with, this was how she presented to me. But initially, she has a history of being in a tertiary care center where she was seen by a retina specialist, traumatic cataract, subhyaloid hemorrhage, NVI, NVG diagnosed. She underwent, a lens aspiration, PPV, injection Avastin. And then later, after those procedure, she was later found to have a staphyloma in a regional medical college, underwent enucleation and implant. And in that pathology, it was written high-grade neuroendocrine carcinoma. And this is how she presented to me. So she had this large lesion, orbital mass sitting over there. This is the implant that you see here. I was still not convinced about, the high-grade neuroendocrine carcinoma. In my mind, I was thinking probably it could be retinoblastoma. And a biopsy was done, and it was proven retinoblastoma. So this is a patient who had been misdiagnosed for possibly an endophthalmitis or a fungal, infection in the eye, or a uveitis, which I don't have what the initial diagnosis was, but only the procedures that were done. Intraocular surgery was done, and the patient counseling is very, very important. Although with strict patient counseling, we lost this patient to follow, because this is after 3 cycles of our intensive multimodal treatment protocol where the tumor completely regressed. So the parents were convinced, being from the village, that she doesn't need any more chemotherapy, and then they were literally lost to follow up. So treatment discontinuation also happened in this patient. So at various level, we face different challenges in these patients. So we all know that the challenges are, of course, in the low-income countries, advanced retinoblastoma, improper enucleation technique, lack of histopathological evaluation of the enucleated globe, and intraocular surgeries, which should be avoided. So the global burden of orbital retinoblastoma, when Dr. Murli spoke about it, we all know that in the developed countries, in Western countries, it's less than 20%. But in our part, we see around 6 to 60%. In our series, it was 6 to 8% orbital retinoblastoma, but in South America and in Africa, and this is the paper from Ethiopia, where they have found almost more than 50% presented with proptosis. So this is definitely a burden in the low-income countries. So we know how conventionally orbital retinoblastoma was treated: exenteration initially, then addition of radiotherapy and then chemotherapy was subsequently added with high mortality rates. So our major concern, we did a project and I was very, very fortunate to be with Dr. Honavar in this project of orbital retinoblastoma. So basically it was live salvage. So what we thought was like, we need to chemo reduce the tumor and then, complete surgery clearance. But even after surgical clearance with enucleation, you're not sure about microscopic clearance, surgical residual. And then we also want to prevent systemic micrometastasis. So what we did was slightly different from the COG protocol, was high-dose chemotherapy. When I say high-dose chemotherapy here, it's an escalated dose of the regular vincristine etoposide carboplatin combination. We do 3 to 6 cycles initially. After every 3 cycles, we evaluate these orbit of these patients with MRI in order to assess radiological regression of the tumor. After we are sure that there is a radiological regression, the child goes for enucleation. Almost these eyes come for thysis bulbi. And then after that, we beat the microscopic surgical residual with external beam radiotherapy, all these patients, and we complete the cycles, 12 cycles in these children. So I'm just going to show our results. So initially, we evaluated 40 cases in multimodal and we found 90% survival in these patients. And this is recently that I had collated the data where we just looked into the primary orbital RB. So when we say about orbital retinoblastoma, it could be either primary or secondary, but we just looked into the primary orbit of 44 cases and we found 95% 10 years survival. And I would like to highlight here, these are patients who are who doesn't have systemic metastasis at presentation. It's only orbital retinoblastoma. So this is how the pre-treatment looks like. Post-neoadjuvant chemotherapy, we get something like this is bulbi and
it's very important, but I'm just going to ask you to summarize, please.
Right. So the survival rate, what we had was 90% in these children. And well, so this is what I would like to share from Indian perspective.
Thank you so much for that. Very important and very relevant. Moving on now to the genetics of retinoblastoma. Our next speaker is Dr. Helen Demarais from the Hospital for Sick Children, Toronto, Canada. And for the discussion, we have Dr. Usha Kim, who's the head of oculoplasty and oncology at Arvind Eye Hospital, Madurai. So I'll be sharing both their presentations since they were unable to join us. So I'll begin with Dr. Demarais' presentation.
Hi, everyone. Thanks for the opportunity to present to you today. I'll be giving an update on what's new and upcoming in retinoblastoma genetics. Of course, to do that, we should start a little bit at the beginning. We all know that most retinoblastoma is caused by loss of both copies of the RB1 gene, termed M1 and M2. RB1, located on chromosome 13, has roles in control of cell growth and preservation of genome integrity. In 2009, we learned of a second form of retinoblastoma, which is initiated after amplification of MYC-N. Located on chromosome 2, this oncogene has roles in regulating cell growth and division. And the form of retinoblastoma one has consequences for heritability. Heritable retinoblastoma occurs when the M1 is inherited or acquired early on in development, such that the patient has a constitutional M1 event, germline is affected. Individuals with heritable retinoblastoma have second cancer risk. Future offspring is at risk as well. All bilateral retinoblastoma have the heritable form, but some unilateral patients do as well. Non-heritable retinoblastoma do not carry a constitutional variant. These are most unilateral patients, and they can have either an RB1 null or MYC-N amplified retinoblastoma. And you can begin to see that in order to uncover heritable or non-heritable form, phenotype alone cannot tell us that. In his latest review in the New England Journal of Medicine, David Kopernik nicely summarizes all the available evidence to postulate how the MYC-N and RB1-driven forms of retinoblastoma are a result of their origins during different stages of cone cell development. MYC-N amplification in an immature cone precursor leads to retinoblastoma. It's the maturing cone precursor at a later stage of cone development that's uniquely predisposed to retinoblastoma occurring after RB1 loss. Some of these budding lesions arrest at the benign stage retinoma, and of course retinoma research has shown us that these lesions are senesced. They have an upregulation of P16 and P130, and it's escape from the benign form of retinoma that's driven by additional genomic changes that lead to full-on malignant retinoblastoma. And these genomic changes include somatic copy number alterations in those regions we all know about, chromosome 6p, 1q, 2p, 16q, and others. Single nucleotide variations as well are present in retinoblastoma in genes like BCOR, and also epigenetic changes, for example, in spleen tyrosine kinase, or SYK. And research into these areas and understanding the function of the genes on the somatic copy number alterations, those regions of gain or loss, or the consequences of variations in the other genes, these make interesting targets for development of therapies and understanding prognosis of disease. Genetic testing precisely identifies risk, though, based on those originating genomic changes or genomic development of retinoblastoma. In the absence of genetic testing, we might know that a bilateral patient has heritable retinoblastoma. We don't know the precise RB1 mutation that they might have, and therefore we can't screen family members or future children. For unilateral patients, we don't know if they have heritable retinoblastoma without genetic testing. Genetic testing to identify the mutation in their tumor, and if it's present in their blood, would tell us, would the other eye be at risk at any point? Is there a risk of second cancers? Are any family members at risk? Or how can we distinguish between MYC amplified or RB1 null retinoblastoma? And I have an asterisk there because, of course, if that eye were enucleated, perhaps histopathology could show us the difference. But in the absence of histopathology or removal of that eye, we don't know, and genetic testing could help us figure that out. Because of the impact of management that a constitutional RB1 mutation has, the 8th edition of the AJCC Cancer Staging Manual included the heritable H trait as an important factor in the classification of retinoblastoma. Knowledge of patient and tumor genetics has consequences for patients throughout their life course, from infancy into adulthood, and we'll look at some of these phases now, beginning with genetic testing and counseling at diagnosis. We know now that genetic testing and counseling are part of the standard of care. Knowledge of one's personal and familial genetics can really empower patients to act appropriately throughout their life course. RB1 has known to be inactivated in a number of ways and has traditionally required a multifaceted approach to identify the various null variants, intronic variants, or promoter hypermethylation that can cause inactivation of RB1. Now, new next generation sequencing technologies are improving their ability to sensitively and specifically detect RB1 mutations, and these have allowed many labs to start offering such services. It's particularly important because of the global challenges in availability, accessibility, and quality of genetic services. And so here I've shown you some images from the University of Nairobi, where the retinoblastoma team is actively pursuing improvements to their genetic testing. They're trying out NGS as well as patient-informed counseling resources to support patient knowledge of their personal genetics. Biomarker detection is another important area of work. For a while now, the idea of using the tumor-specific RB1 mutation or the somatic copy number alteration profile from tumor DNA has been used to look for minimal residual disease by probing the CSF or bone marrow. And more recently, this idea of liquid biopsy has found some really exciting applications through aqueous humor and blood. And so the ability to detect these same tumor-specific markers in the cell-free DNA found in blood or aqueous humor is an emerging area of work. Next, let's look at family planning and early diagnosis. Prenatal testing has been a mainstay in retinoblastoma for a while now, where the familial RB1 mutation is known. The fetus can be screened through amniocentesis or chorionic villus sampling. More recently, Amy Jarish's team has developed a non-invasive test by examining fetal cell-free DNA in the mother's blood. And so that's really exciting because amniocentesis and chorionic villus sampling can sometimes have some unanticipated effects. For families wishing to prevent retinoblastoma in the next generation, in vitro fertilization with screening of embryos through single cell biopsy can also screen out affected embryos and only the unaffected embryos be brought to term. In the next generation, things are looking even better. Currently, prenatal detection coupled with early delivery can lead to better outcomes, as tumors can be monitored regularly and treated at first appearance. Shown on the image here is a tumor visible only by OCT, treated with laser and preserving the child's vision. In future, possibilities expand, with current research focusing on improving capabilities of liquid biopsy for detection of the tumor profile right from diagnosis, and research into identifying druggable targets within tumor profiles are really opening up a world where biopsy at diagnosis can identify the distinct tumor profile and direct precision treatment, and then routine biopsy can be used to monitor response. Finally, second cancer surveillance is an important area. We know that a top retinoblastoma research priority is to discover better screening for second cancers, as we are not meeting this need sufficiently. Cell-free DNA may also hold the answer here. The CHARM study is one such study that is enrolling heritable cancer survivors and screening cell-free DNA in the blood with a cancer panel and a multifaceted approach. However, they're not enrolling retinoblastoma patients consistently. Although there's work being done to get some funding to add retinoblastoma to that trial. The MSK Access Group as well reports applying some of their work to retinoblastoma survivors, but so far, to my knowledge, they're looking at somatic variants. So this is an important area of research for the retinoblastoma community to address. Can we detect early second cancers in the blood and provide earlier treatment as well, and save lives of retinoblastoma survivors in this next phase of their cancer journey? In summary, retinoblastoma is initiated by either biallelic RB1 loss or MYC amplification. Additional genomic, genetic, and epigenetic alterations influence malignant transformation. Genetic testing can distinguish between heritable and non-heritable patients and be used to screen at-risk family members and provide family planning options and early detection for the next generation. And cell-free DNA really is showing potential for genetic diagnosis, detecting prognostic biomarkers or directing treatment, and surveillance of non-ocular second cancer. Thank you very much.
I will share Dr. Usha Kim's presentation now. So I think there's so much to discuss in retinoblastoma that it's an exhaustive topic. But I would just request all of you to stick around. We do have a very interesting quiz coming up once the symposium is done. Right, give me a second.
Thank you, Dr. Santosh, for giving me this opportunity to talk about genetics and retinoblastoma in Indian perspective. The common questions that are asked by the parents are, will the proband's vision be affected? Will one or both eyes be affected? Will the next child be affected? All these questions can be answered with a genetic analysis of both the somatic or germline mutations. Retinoblastoma, as you all know, is caused by alterations in gene called the RB1 that protects the cell from becoming a tumor. 2 alterations are required for developing retinoblastoma. The cost of the genetic analysis was very high in order to make the genetic testing affordable, and in a developing country like ours, we developed methods in a sequential manner as shown above, and this has reduced the time by half and cost by 1/5. With a sensitivity of about 95% for somatic mutations and 90% for germline mutations, and we've made it at an affordable cost. Now this patient's proband was brought to us at 4 months of age. Mother's right eye was enucleated. Subsequent follow-up, when the patient was on chemotherapy, the mother was found to be pregnant. Mother was asked to come right after delivery. The 12-day-old sibling was brought to us with a group B retinoblastoma of both eyes. Similar looking twins, no family history of RB, no mutation in parents' blood. Twin A had squinting with bilateral RB. Twin B had a retinal scar, so we were suspecting a regressed RB. Twin A had a de novo germline mutation in the blood, and twin B had no mutation in blood. It was non-identical twins, which eliminated the risk of screening the twin B multiple times. The proband presented to us at 36 months of age with no family history, unilateral RB, group E. And unfortunately, in this child, there was a germline mutation identified in the blood, which meant that blood should be screened in all unilateral patients as well. Proband presented to us at 26 months of age with right eye group E retinoblastoma. Germline mutation was identified and closely monitored. Patient turned bilateral RB during the treatment period. An analysis of the parents showed the father as an unaffected carrier, and thereby we predicted a higher risk for the next sibling. Proband's wife is 2 months pregnant. There was a familial RB with 4 affected members. The proband and the mother had the same type of deletion. Family wanted to know the risk of RB in the growing embryo. Prenatal testing was done by amniocentesis, and the same deletion was found in the fetal DNA. In this particular patient, left eye was enucleated at 6 months of age, and since there was no mutation found in the patient's blood, it was predicted less than 1% chance of getting RB in her offspring. Next patient, the left eye was enucleated at 2 years of age with no history of RB, non-consanguineous family, no mutation was identified in the blood. There was no risk of developing a secondary tumor. We made a panel of about 20 genes that are identified in the genomic regions that were altered in the tumors, and 5 genes were identified for which currently drugs are available for other cancers that can be repurposed for retinoblastoma. About 30% of our patients do not respond to the existing chemotherapy regimen, and sometimes we end up enucleating both eyes. Our recent findings suggest that there are stem cells that are actually quiescent during the treatment period but become proliferative after the treatment has been stopped. So we are developing methods to target these cells. We have established cellular models for the chemoresistance and now screening the drugs that can overcome the resistance and reduce the tumor burden. We are also setting up the zebrafish model that can serve as a drug screening tool. Thank you very much.
Thank you. And I'm going to move on to the next presenter now. It's my pleasure to invite Professor Aido Didi Fabian, who's the professor and director of Sheba Global Ophthalmology, Sheba Medical Center, Tel Aviv, Israel. And he'll be talking to us about retinoblastoma. How are we doing around the world in 2024? For the discussion, we have Dr. Seema Das, who's the head of ocular oncology at Shroff Charitable Eye Hospital, New Delhi.
Thank you for the introduction. I'll just share the screen. Can you see my screen?
Yes.
Okay. So thank you for the invitation. I was asked to answer the following question about RB around the world in 2024. And frankly, my immediate answer would be, I do not know. We are in the process of collecting the real world data. So please ask me again next year. But since I have nearly 8 minutes to speak, I'll try and do my best. So first we need to know how many new cases of retinoblastoma are there in the world in a year. We know that the incidence of RB is constant across countries, and we know the birth rate in each country, so we can easily do the calculation, the result of which is about approximately 8,000 new cases every year. But how are they distributed globally? So most of what we know about RB comes from high-income countries, but in fact, these cases from North America, Europe, and Oceania represent about even less than 10% of global RB, whereas most cases occur in low and middle income countries in Africa, Asia, and Latin America, over 80% of the cases. Now, in September 2018, the WHO, the World Health Organization, announced a new effort, the GICC, the Global Initiative on Childhood Cancer, with the aim of reaching at least 60% survival rate for children with cancer by 2030. These are the 6 index childhood cancers that were chosen. Retinoblastoma, one of them. Now, in order to reach the 60% goal, you need to know the baseline status. What is the status now? So in 2017, we founded the Global Retinoblastoma Study Group with an attempt to recruit all RB treatment centers across the world. All the panelists, or most of the panelists in this symposiums, are taking part, and many, many others. The idea was to have a very simple cross-sectional analysis of treatment-naive children that presented locally during that year, 2017. So basically, our goal was to report the very basic data on RB, but on a global scale for the first time. We managed to enroll more than half of the annual global incidence, more than 4,000 children from 153 countries, many, many collaborators. It's a lot. Is it enough? I'm not sure. This is the distribution with dark red representing countries with more than 100 patients per year. So USA, Nigeria, Egypt, Pakistan, India, China, and Indonesia. Here are some of our key findings. So nearly 100% of children from high-income countries, this column, present with intraocular tumor, and their presentation age is less than 2 years of age. Whereas half of children from low-income countries present like this with extraocular retinoblastoma and at a mean age of 3 years. What about the rate of familial retinoblastoma? So the answer is, it depends. It depends on where the child comes from. So in high-income countries, the rate was 8.3%, whereas in low-income countries, it was as low as 2.8%. And the reason, most probably, is because children from low-income countries that present exactly like I showed you in the previous slide do not make it to childbearing age. So the pool of familial cases in these countries remain low. We showed on another sub-analysis, this was done by Andrew Stacy, my colleague from Seattle. We showed for the first time that in Europe, the incidence of retinoblastoma is actually higher than we thought. 1 in 13,844 live births, compared to the historical figure, 1 in 15 to 18,000 live births. And on regression analysis, the only risk factor for higher incidence was positive family history. So in fact, the genetic pool of RB is on the rise in Europe. We then asked centers to continue monitoring those children that presented in 2017 for 3 years. So the latest outcome data we have on a global scale is from 2020. In high-income countries, nearly 100% of children survive after 3 years from presentation, whereas in low-income countries, just over 50%. But when you look at the capture rate by income level, so low, lower middle, upper middle, and high, in low-income countries, most of which are in Africa, we enrolled only 40%. That's in blue. We missed about 60%, so a lot, but not enough. We further looked into risk factors and found that if your risk factors for poor survival, and we found that if you're born in a low-income country, in Malawi, for example, or Uganda or others, and diagnosed with retinoblastoma, you have nearly 17 times increased risk to die as an independent factor than if you were born in a high-income country, in the UK or US or other high-income countries. Advanced tumors, CT4, so extraocular disease at presentation versus or compared to CT1, early intraocular disease, 9 times increased risk. And this is the respected Kaplan-Meier. So more than 90% survival after 3 years for intraocular disease, CT1, 2, and 3. But if you presented and diagnosed initially with extraocular disease, CT4, only about 30% survival after 3 years. 1 in about 30 children with retinoblastoma still loses both eyes, which is tragic, but saves lives. About the same time, we published the real-world data. Emily Wang and Jason Yum from Hong Kong, which are part of the global collaboration, published a 40-year systematic review and meta-analysis on global retinoblastoma. As expected, poor survival in low-income countries, mostly in Africa, looking at the details, while in middle and high-income countries, 1980s until 2020, survival rates improved since the beginning, since the 1980s. In low-income countries, this column, it remained about the same. And surprisingly or unsurprisingly, they calculated precisely the same 57% that we found in 2020. As mentioned, we are currently enrolling children for the 2024 presentation, 2027 outcome study, and we have a new video. So compared to the 278 centers we had in 2017 or 2017-2020, we now have over 430 centers on board. We mainly focus, at present, we focus to increase the capture rate in populated countries such as Nigeria and China and India and others. In addition to the presentation and follow-up data, we also asked for the available modalities in each center. So this is relevant to 2024. So it's presented here, analyzed at 3 levels: center, country, and in the next couple of slides by economic group. We have data sent by now by 347 centers from 127 countries. So enucleation is a prerequisite to be defined as a retinoblastoma center, so 100% of the centers. Pathology available in 97% of the centers and in 98% of the countries, and systemic chemotherapy in 95% of the centers and 94% of the countries. If you look at these, this is the core team you need in order to save a child. Analysis by economic grouping, so pathology available in 92% of low-income countries and 100% of all the remaining countries, middle and high-income countries. And systemic chemotherapy available in 84% of low-income countries and over 93% of middle and high-income countries. There's more information on focal therapy, availability of genetic tests, etc. So Amita and then Manesh showed the increase in use of IAC in India. Here's the trend in Africa, 2024. So IAC and IVIC, so intravitreous. So in 2017, only IAC was available only in 2 countries. I think it was Egypt and South Africa, and currently it's available in 8 countries. Okay, intravitreous chemotherapy was available in 2017 in 7 countries, and now more than half of the African countries, 20 countries, use IVIC. We need to remember that these modalities are efficient for eye salvage when patients present early enough, and in too many countries, this is still a major problem. So thank you to all co-authors, about 700. I echo Dan Gamba's words, collaboration is the way forward, especially in a rare disease like retinoblastoma. Thank you.
Thank you so much for the wonderful presentation. Dr. Seema, would you like to share your screen?
Thank you, Mritika. Yeah, are my slides visible?
Yes.
Thank you very much, Dr. Devi, for this update. And thank you very much for the wonderful work you have been doing. And we all are aware about the work that you have been doing and how it has made a difference. And hopefully with the new study, we will be seeing more and more data, and it is going to make more and more difference in the outcome of RB across the world. So just in line with what you have just shared, what is the scenario in India? Again, this is not what we are seeing in 2024. That probably we are going to see down the line a year or 2. But this is what we have been doing in the last 2 years. And data of this study is what I'm going to share is mostly the initial preliminary results from the collaborative study in India, which Dr. Amita has earlier shared the chemotherapy data, and this part is more of the demographic data. The study is still continuing the follow-up information. We have stopped the recruitment, and as you can see across India, there were 20 centers which has participated, and we enrolled about 1,120 patients in 3 years. And of course, it was more in the last 2 years because the first year, the recruitment was a little delayed because of the COVID and other issues. So hopefully we possibly have captured about 1/3 of all the new patients that is seen in India every year, possibly a little more than that. If we compare the results with the global RB data and as well as the analysis of the subset of the Asian data, and age at presentation is not too much different what is found in the rest of the world and also in the rest of the countries of the Asia. Laterality did mention that, unilateral disease tend to present at a little older age group. We have found a little trend in our study, but we are yet to do the final analysis, go into the little depth. Though the age unilateral versus bilateral, the laterality, not too much of difference we are seeing in the Indian data as compared to the rest of the data. What we are finding is a striking difference with the Asian as well as the global data in the stage of presentation. And this is 23.2 of stage 3 and stage 4. And if I include stage 2, this is 25%. So about 1/4 of all the RB that we are seeing in India still continue to present as extraocular disease at presentation, which is very, very significant. Now, if we just try to plot all the patients, the geographic origin of the patients of this study across the map, this is what we find for all the patients at all stages from 0 to 4. However, if we just cut short it to stage 3 and 4, we can see a very striking divide between the north and the south. So this is not a geopolitical divide. We don't want to be divided by our RB. We want to kind of collaborate and be united with RB. However, there is a difference in the advanced disease or the extraocular disease in the geographical pattern of distribution, and more patients seems to be concentrated in the northern part of the country, the northern belt. And we all know this is the belt where the population density is very high in India, with possibly the socio-cultural parameters not as far as with the southern part of the country, and also availability of the treatment resources and the dedicated centers to treat RB are possibly not as developed as in the southern part of the country. And these are the numbers recruited as it tallies with the total numbers also. However, with increased numbers, the stages of presentation also seems to be far more advanced than we are seeing in the rest of the country. So this is very, very important because we need to know where we are going to direct our resources. We have limited resources if we have to kind of improve the outcome of RB. And awareness initiatives and the resources, as well as all the advocacy initiatives, needs to be directed at the areas where there is a need if we have to eventually make a difference in the outcome of retinoblastoma in India. So the lag time for diagnosis, sorry for this, I think my slide is just getting overlapped. So what we have found here that the parental lag time, so delay at the level of the parents was maximum at about the whole lag time into parental time versus the diagnosis and the treatment time, the maximum delay was at the level of the parental lag time, which just tells us that there seems to be a delayed recognition by the parents. And if we do try to look at the factors which could predict the increased lag time, it was at par with what has been found in the global RB studies as far as the parental lag time was concerned, which means that lower socioeconomic status, the literacy, as well as the educational levels were associated with the increased lag time. What came out strikingly was whenever a child was seen by a non-specialist other than an ophthalmologist or a pediatrician, all the lag time seems to be delayed right from the parental as well as the treatment lag times. What we also found interesting was that when the symptoms were leukocoria versus non-leukocoria, means probably the presentation was a little atypical, and also bilateral disease where the treatment is more complex rather than just only enucleation, the treatment lag time was delayed, which could be an indirect indicator of the availability of treatment resources across the centers of the country. So this is what I was talking about. Whenever a non-specialist is seen, as we can see here, just about 12% of the patients got the diagnosis of the first visit, compared to the ophthalmologist who have fared a little better, as well as the pediatrician, where more than 50% could be diagnosed at the first visit itself. So our awareness and training initiatives may not be directed only towards the community, but we also need to include the healthcare providers, not only the ophthalmologist as well as the pediatrician, but also the non-specialist, the physician, as well as the traditional medicine practitioners, if we again have to diagnose and treat these patients at an early stage. As far as the baseline workup, including UA and imaging is concerned, almost 90% got a UA and imaging either in the form of MRI or CT before the treatment was initiated, which is pretty good considering the resource constraint of general anesthesia and other facilities across the various centers. Genetic testing, we have been talking about it, and the global RB data as well as the Asian data shows that at least 20%, 35% and 36% of the centers do have the facility to provide a genetic testing. And from the global RB data, 20% of the LMIC countries also, I think, have mentioned the availability of facilities for genetic testing. However, at least from this data cohort, what we are seeing from India, just about 6.2% of these patients underwent genetic testing at the initial presentation and the subsequent visits. The treatment advice, this is again in tune with what generally we have been discussing. Almost about 2/3 of the patient, chemo reduction remains the first line treatment advice. Primary ISC, just about 2.8% of the patients were advised. This again reflects the availability of the facilities as well as the stage of the presentation where many patients might not be suitable, even the unilateral ones, for primary ISC. Primary enucleation, surprisingly, was advised at for a slightly lesser percentage of patients as compared to the global RB as well as the Asian data. Again, partly this could also be attributed to the reason that many of these patients are presenting at an extraocular stage where primary enucleation is anyway not feasible. And also sometimes as proportion of patients were advised neoadjuvant chemotherapy just to improve the treatment compliance, and we are just going into the deeper analysis of this part also to get a better understanding of how much of it was neoadjuvant, which actually are patients who could undergo primary enucleation also. Now, what is striking is, as of now, the follow-up duration of this cohort is about 8 months, and we have found the treatment abandonment is about is at about 10.8%. And if we compare the historical data from India, from the south, the reported study, the abandonment is at about, or the treatment refusal or abandonment is about 7%. But if you see conventionally the data from the rest of the northern part of the country, it ranges from somewhere from 30 to even 50% or more. So considering that possibly this 10.8% treatment abandonment is something which we should say is an improvement from what has been there earlier. And hopefully with a more organized and a collaborative effort, we will be able to make a difference in the other parameters and improve the outcome. So this is all I wanted to share. And this is the summary of the intervention and the outcome which you have found from the study.
Thank you so much, Dr. Seema, for sharing the results of such an important study, which is the aim of this Retinoblastoma Awareness Week, that we improve the outcomes. All right, moving on to our final talk of this symposium, I'd like to invite Dr. Ashwin Reddy, and he is an honorary consultant at Moorfields Eye Hospital and the lead clinician for ophthalmology and retinoblastoma services at Barts Health NHS Trust, UK. And he'll be telling us the top 10 pearls and salient points from the symposium.
Thank you very much. We have northern lights here, so I might break up due to the internet and so forth, but bear with me if you can. This is the first time I've had to give a presentation, well, write a presentation a couple of minutes before I give it. So it's quite an experience. But this is really a recap, what I think is relevant from the 10 talks we've had. And for those of you who've been through this symposium, it's hopefully recap things that you heard about an hour and a half ago. And if you're like me, you might have forgotten those things. So Dan started off, Dr. Gombos, about the future, and really it is collaboration, collaboration, collaboration. We can't move retinoblastoma forward unless we're all collaborating and talking. It's quite nice, having been doing this for a few decades, to see that there is a culture of collaboration within retinoblastoma doctors around the world. Okay, so then Ashwin Malipatna talked about grouping and staging, and as I mentioned at the beginning, there's some confusion with grouping. There is the 8th edition. I can see the resistance. ABCD is quite easy to remember, but this CT, this and that and the other is difficult to remember. It does take time to learn. In the UK, we all use ABCD and we use this as well. Once you get into the habit of it, it's actually pretty straightforward. Most of our patients are group D and E, so actually you're looking at CT2B and CT3C, and that's it. So actually it's not that difficult. Neuroradiology is going to be used more in grouping, and so that's really interesting to hear. And it does make sense, because before we had poor clinico-pathological correlation with neuroradiology results. That's improving all the time. So I think we're going to get there where neuroradiology becomes part of this grouping, not just the ophthalmologist making the call. And the ninth edition is coming out soon. Okay, Dr. Wilson, Matt. So he emphasized again, stage 4B has poor survival with below 20% survival rate. And with adjuvant chemo, it seems to be different cycles in different centers. We use carboplatin etoposide vincristine, Joe, as it was originally called, as it was developed in London. But we use actually 4 cycles of adjuvant, not 6 cycles, for post-lamina optic nerve invasion or massive choroidal invasion. Dr. Shields, talking about intravitreal chemotherapy, 20-year results, same as 3 years. Intra-arterial chemotherapy, she does not consolidate after IAC. We see recurrences and relapses after IAC. Sometimes we treat that with laser cryo. We do give repeat cycles of intra-arterial chemotherapy. So we're not seeing the results that some of these other centers are seeing. What she found was similar results at 5 years as at 2 years, which is good. We're seeing relapses, recurrences after 2 years. And this is the interesting thing. When I came and gave a talk at the All India Ophthalmological Conference in Delhi, I think it's 2014, 15, I talked about IAC. We were just using it there. We've been using it for about 4 years. And it was thought that this would never catch on in India. It's too expensive, it's too complicated. India's a poor country. But as we've heard, it's being used 25% of the time in India. And probably that's going to happen in Africa and other countries as well. So for me, that's really interesting. Okay, the role of intravitreal chemotherapy, Francis Mounier. So you can treat vitreous seeds that have landed on the retina with intravitreal chemotherapy, but not if it's implanting, which is interesting. So 90 to 100% success rate with IVC. If you're not getting that, there's a problem. We worked out that there was a problem, and that was because of our Malphilan manufacture. But if you're getting resistance to IVC, there's got to be a problem with something along the line of treatment. So you need to think why. Topotecan's success rate has increased with higher concentrations, then it's very safe. If you do give intracameral chemotherapy and it's hit, and you can do UBM of the ciliary processes, use a plaque. So they're important points. So Jesse's talk on cell-free DNA, which we're doing with the Birmingham group, 6P gain, she's mentioned over the years, very important for salvage. So we'll need to look at validation and accreditation with this procedure for pseudoretinoblastomas. I think it really has an important role for pseudoretinoblastoma, especially if it can be done by non-retinoblastoma specialists, even if they have a 1% suspicion of retinoblastoma. If it's something that can be done by them, I think it really will have a role. We've just had a misdiagnosis in London, and so it's still happening. So this really is important. Also, if you have a patient who had the vitreous hemorrhage 5 years after treatment, you may think it's a treatment issue, particularly if they've had intra-arterial chemotherapy. In her case, she found that it was RB, and enucleated and it's found to be RB. So it really has a role. And it's a bit like intra-arterial chemotherapy, may not be in all centers in India at the moment, probably will be in 5 to 10 years' time. And it requires validation accreditation, where collaboration comes in. Histopathology, again, very important for pseudoretinoblastoma. And that's where cell-free DNA comes in. This is by Dr. Eagle. Peripapillary choroidal invasion is an important factor, which I hadn't quite appreciated. And we've had issues where we've only had one pathologist, and that's only one point of failure. So it's always important to have two pathologists, which I think he was discussing about a central area of assessment and things being missed. And so I think it's really important in retinoblastoma centers to have two pathologists, at least for them to discuss with each other or to bounce ideas off each other. Orbital and metastatic retinoblastoma from Murali. So this is important. So if you've got a parents, and we've had this, where they say, I've seen a white reflex a year ago, unless they've got a orbital RB and it's almost in the brain, that probably that white reflex wasn't relevant. We've recently had a case who wasn't treated for 14 months, and they do have metastatic CNS disease, unfortunately. So knowing the 14 months untreated, they're the ones that are dangerous. They're the ones that, if they're missed, these kids will die. And it was interesting in North America, they had 21 patients with 4B, which is quite a lot. So I didn't think they'd have that in North America. And as for our patients, once CNS mets are there, the prognosis is very poor. And really randomized studies, and that has to include India, would have to be considered to see what can be done in this group of patients. Helen had a nice overview of genetics. And in the UK, we have prenatal diagnosis. So we're using cell-free DNA. Mother's pregnant, mother or father had RB. We can, on the NHS, we can tell if the baby has the same genetic change. And that's validated and accredited. And don't forget second cancers and what we could possibly do for second cancers. And Didi, important numbers, 8,000 new cases per year. The global initiative, which I hadn't appreciated, 2030, 60% survival rate, which is actually the low-income countries are getting 57%, but that's got to be in all countries. 3% in low-income countries have familial RB, and sadly 1 in 30 will lose both eyes but will live. So I thank you for inviting me. You can move on to the quiz now, and I look forward to seeing you all in Goa in December.
Thank you so much, Dr. Ashwin. I think you did the toughest work for this very long symposium. You kind of summarized it so beautifully. I think your presentation was brought out all the important points, and it will be really, really helpful for those who are watching this. All right, Rolika, it's all over to you. We can go ahead with the exciting quiz. I'm sure everybody's been waiting for that.
Yeah, thank you so much, Mithika. And I thank all the presenters for making it very easy for the people who are participating in the quiz, because they have answered a lot of questions that I have on the quiz. So I hope it helps everyone. And let me just share my screen. Is my screen visible?
Yes.
Yes, Doctor.
Okay, so thank you. A very happy Mother's Day to all, first of all. And this is a very interesting retinoblastoma week and the retinoblastoma quiz. And just to brief you all about the quiz rules, the quiz will be played on Kahoot. And you have all your time. Please go ahead and log on to www.kahoot.it or download the Kahoot app. And there will be a game pin, and I have displayed the game pin right here at the top. As soon as you start joining, the players will pop up on my screen. There will be 25 questions and followed by many explanations. Each question will have 4 options, and speed and accuracy matters for scoring, and Quizmaster's decision is final. So while you all are waiting, yes, I can see the names pop up. And for everyone's convenience, I will be switching on to the other screen for reference for the Kahoot system. Just give me a moment. Dr. Mithika, even it's okay if you also would like to participate in the quiz.
For those who are still online, if while people are joining in for the quiz, if there are any comments or any further discussion that they would like to do, since we could not take it during the talk itself. A lot of people have joined.
Yeah. My screen is clearly visible, right? So that it's easy for everyone to see the questions. Okay, there might be a lag when you are seeing the YouTube page, and so I suggest that you log on to the Kahoot app. So whatever I might be saying might come to you after, like, say, a lag of 3 seconds, but the question will pop up in front of you, so you will be in time. So don't be worried about that, because I'm getting questions about Oh, that's an interesting name. Somebody is there as RB boy. We do have yeah, we do have few of the panelists there. Dr. Mritika, would you like to take some of the discussions till the players are joining?
Yes, absolutely. Dr. Seema, Dr. Feroz, Dr. Murli, Dr. Ashwin, are any of you still online? Hi, Dr. Feroz. Dr. Eagle, are you there? I think Dr. Gombos is also there. So I think this was a great symposium. We touched upon new things, we touched upon evolving things and what the future holds. So I'm just going to invite any comments from any of you, please.
May I ask a question to Dr. Gombos on the basis of the initial discussion about intravenous chemotherapy? And as you mentioned that in the first case that was shown that there was a group E and a group C, and you had mentioned that you may go ahead with primary enucleation before the initiation of intravenous chemotherapy. I wanted to know, have you ever seen that since intravenous chemotherapy may hinder with the healing process after enucleation, have you ever noticed any socket changes after primary enucleation and that you have initiated the chemotherapy?
Yeah, thank you. That's a great question. Before I get to that, there are eyes that we all see and you just sort of know it's not going to make it, I mean, you see eyes, particularly with significant hemorrhage, there's pain, there are EIs and then there are bad EIs. And so, to some extent, I think you do have to think about that when you consider primary enucleation, even for an advanced EI. Getting to your question about post-surgical complications, and by that, I'm sure you mean the induced pancytopenia from chemotherapy. I've always been very careful in covering these eyes with, so I primarily use hydroxyapatite. I still use donor sclera. I usually wait about 3 or 4 weeks before they resume the chemotherapy. And I have to say, doing all those things with very meticulous closure of the Tenon's capsule. I mean, I close the Tenon's capsule in a triple layer fashion. I do a purse string first, then I do 2 and second layer of interrupted. I have never had a problem, but I attribute that primarily to a very meticulous closure. Sort of every time you think you put enough sutures, put in more sutures, and then using sclera. And I think for me, that has worked well. And touch wood, I haven't had a problem.
Right. And on the contrary, Dr. Feroz, I believe that what you prefer is enucleation after the 6 cycles of chemotherapy. Do you see any difficulties while you're enucleating a Thicicle eye?
Okay, so Thicicle eye means in orbital retinoblastoma.
Right.
Yeah, no, not really, Rolika. So in fact, even there might be a little bit of fibrosis wherever there has been an orbital extension, right? So we kind of meticulously dissect. And if at all there is Tenon's involvement, we also excise the Tenons along with it. And some orbital tissue for histopathological evaluation in and around the area where the extraocular extension was. So no, I have never found any difficulty in enucleation if there is a thysis bulbi. And something that I really want to highlight here is there are, kind of practice where you don't put an implant in an orbital retinoblastoma, because radiation is the next step and people are kind of concerned whether implant is going to hinder the radiation. But in our practice, we always put an implant during the enucleation of an orbital retinoblastoma. And most importantly, because after radiation, there is going to be a lot of socket contraction and scarring. So it's the regular enucleation that is done orbital retinoblastoma extraocular extension also without any difficulty. I have not found any difficulty in Thicical eyes. Yeah. So put an implant. The child is definitely to go for radiation after that. Yeah.
Right. So both schools of thoughts can be like are equally okay and preferable. Right.
Rolika,
So
I think
may
Dr.
I?
wants to say a few.
Yes.
I have a question for Farouz. You talked about you practiced in a country where they did vitrectomy for retinoblastoma. What was the sort of follow-up on such cases? Did you make any comments on that?
Yeah, so Dr. Eagle, these patients were referred to me for follow-up for intravitreal injections because they thought it's much more safer to give intravitreal injection, although they have surgically cleared it. So what I have found is eventually, I don't have the real data with me, but a few of the cases that I have seen, eventually they go for phthisis bulbi, although the attempt has been to salvage the eye kind of, during the tumorectomy. It's just not vitrectomy. Even the tumor is excised. So having a very little of viable retina in an eye where, the entire tumor has been excised and the retina has been excised, most of these eyes eventually go for phthisis bulbi. And in my practice, I've not seen too many. It's just the referred cases which has come. I have not seen any extraocular extension though. So yeah.
Thank you.
Thank you.
Okay.
Thank you, Dr. Eagle and Dr. Feroz. Rolika, do you want to start?
Yes, please. I'll go ahead. Thank you everyone for answering the questions. And I'll move on to the quiz. So as you all are, joining, you can go ahead and join. I can tell the game pin again in the middle. So just to recap here, this is the retinoblastoma week and the retinoblastoma quiz. And the quiz will be played on Kahoot, as I just have mentioned. And please log on to kahoot.it. Anybody who still wants to join in can please go ahead and proceed and join. There will be 25 questions followed by explanations, and each question will have 4 options. The speed and accuracy matters for scoring. The quizmaster's decision is final. And again, the pin is popping up at the bottom, that is 4700594. So please go ahead and join. So let's start with the first question. In the 1930s, which was the first radioisotope used for plaque brachytherapy treatment of retinoblastoma? And your options are cobalt, iodine, ruthenium, or strontium. So try to fixate on the words in the questions so that it's easy to answer. So the correct answer is cobalt, and majority of you have answered iodine, but the first radioisotope ever that was used, and that was back in 1930s, was cobalt to begin with. So the scoreboard shows that Control-Alt-Delete is on top, and RB boy is 922. I guess a lot of people have RB as the initials, so maybe in the end I will request them to send information about their actual identity. So moving on to the next question. Which treatment modality was introduced for retinoblastoma through this landmark paper? And the paper will reveal in a slow process. The options are transpupillary thermotherapy, cryotherapy, intravitreal chemotherapy, or intravenous chemotherapy. And I guess you have a clue right there. It was an AJO and it was by Linkoff et al. So interesting that a lot of people thought it would be transpupillary thermotherapy, but it was actually cryotherapy. And I do have a follow-up question on the same, but before that, let's see how the scoreboard is. Okay, so RB boy has gone up. And the next question, to the follow-up question, is that Linkoff et al. Proved cryotherapy to be effective for which of the following intraocular tumors? And this was the paper, the cryosurgical treatment of intraocular tumors. What was it for? Retinoblastoma, metastatic carcinoma, malignant melanoma, or all of the above? This is a pretty interesting answer, actually. I kind of wished that I knew that everybody would answer all of the above. Actually, the paper was on all the three, but the efficacy was only proven for retinoblastoma. Linkoff et al. Had actually shown that it is not that effective for metastatic carcinoma and malignant melanoma, and there were recurrences or non-regression seen following the same. So let's see how the scoreboard has changed now. Okay, so we have Dr. AM and PS climbing up the scoreboard. And this was the paper which was used for describing the cryotherapy technique. So next question is, a series of 4 landmark papers published in JAMA in 1996 revolutionized which retinoblastoma treatment modality? And I believe this is a very easy one. And it was known as Archives of Ophthalmology initially. The treatment options are plaque brachytherapy, intravenous chemotherapy, intra-arterial chemotherapy, or intravitreal chemotherapy. And I hope everybody gets this right. That is correct. So a lot of people got it right, and that is intravenous chemotherapy. Before the explanation, let's see how the scoreboard has rolled. And a lot of people are climbing up. And these were the 4 papers by Brenda Gali, Dr. Carol Shields, Dr. Judith Kingston, and Dr. Lynn Murphy's teams. And they were all published in the same issue, back to back, and it changed the face of retinoblastoma. So thank you to all the team members for introducing intravenous chemotherapy. Question number 5 would be classify based on international classification of retinoblastoma grouping. And as it has been discussed, this is probably the most inclination towards the Philadelphia group. So it would be A, B, C, or D. And this is an easy one because it has been discussed just recently. That's correct. The answer is Group B. And before we go to the explanation, let's see how the scoreboard has changed. We have Samiksha, ARM, and RB climbing up. And this is the international classification of retinoblastoma. And multiple variations have been given, as have been widely discussed in the symposium also. And just to briefly say that Group A encompasses the small tumors. And this lesion was Group B because it was
I think, Rolika, are you still there? All right, so the quiz is interrupted for the time being because unfortunately those slides I do not have that I can share with you all. So I'm just going to get in touch with her. Rolika, are you back? We can't hear you, you're muted.
I think I'm back. Yeah.
Right.
Sorry, this is the geostorm, right? So which is the common specialty of these 2 pioneers? Go on. It would be either ocular oncology, ocular pathology, pediatric oncology, or radiation oncology.
We can't see your slides.
Okay, just 1 second. Hold on. Let me just get this back on.
And I think you'll have to repeat that question if you can.
Actually, the question has displayed on everybody's screen.
I see. All right, sure. That's fine.
Yeah. So I hope they were able to see it. Are you all able to see it now? My screen is visible, right?
Yes.
So it's okay. I think the question probably got missed out, but I will go on. Sorry, this connectivity issue is pan USA today, but I'll go on. So the scoreboard remains unchanged. But this was the question, and my question was that the two pioneers belong to which specialty? The two pioneers are the ones who have, again, changed the face of intravenous chemotherapy in England and USA respectively, and they're Dr. Judith Eve Kingston and Dr. Anna Meadows. I'll move on to the next question. What are these two legends known for introducing in the world of retinoblastoma? So the options are plaque brachytherapy radioisotopes, intravenous chemotherapy protocols, histopathology patterns of retinoblastoma, or classification of retinoblastoma. Well, the correct answer is classification of retinoblastoma. And the scoreboard pretty much remains the same. And the two people were Dr. Robert Ellsworth and Dr. Algernon Rees, and they gave the classification of retinoblastoma to begin with. And this is just a picture for courtesy because these pictures were taken from Dr. David Abramson's paper. And thank you for the picture. And this is all three of them, three legends in one picture. So moving on to our next question, which pioneer of retinoblastoma is known for his passion for lipidopetrology? Dr. Ralph Eagle, Dr. Algernon Rees, Dr. Jerry Shields, or Dr. H.P. Stallard? For those who are wondering what is lipidopetrology, I will be explaining that in the next slide. Well, the correct answer, well, nearly most of them got, is Dr. Jerry Shields. And Dr. Ralph Eagle does have passion for photography and for making exclusive, designing exclusive ties and scarves though. So that's pretty interesting. And the scoreboard has RB Boy on top and we have new names popping up. And Dr. Jerry Shields with his wife, Dr. Carol Shields, and I've taken this picture specifically because of the little butterflies on the scarf. And lipidopetrology is basically his passion for studying butterflies and moths. Moving to the next question, who was the first to advocate enucleation for retinoblastoma? Was it Peter Poyes, Gerd Meyer-Schwickerath, James Wardrop, or Henry Stallard? It's good to see that more people have joined in. That is correct. The answer is James Wardrop, and majority of you all got it right. And the scoreboard has some changes, but it pretty much remains the same. Okay, so James Wardrop in 1809 was the one who first advocated enucleation for retinoblastoma. Peter Poyes was the first who described retinoblastoma, and that was back in 1597. Henry Stallard in 1930s introduced the use of cobalt radioisotopes for the treatment of retinoblastoma, which was also the first question. And Gerd Meyer-Schwickerath in 1950s introduced photocoagulation by xenon arc. Moving on to the next question, according to the European RB group guidelines, which is an absolute indication for secondary enucleation? So I'm talking about the absolute indication. The options are neovascular glaucoma, rhegmatogenous retinal detachment, refractory disease despite salvage treatment, obscured view secondary to intravitreal hemorrhage. And majority of you have got it right, then that is refractory disease despite salvage treatment. And we have a good change in the scoreboard. That's good to see. And moving on to the concept, and that was given by Stathopoulos et al. And they had stated, the entire European retinoblastoma group had stated relative and absolute indications. The other options that were there were the relative indications for secondary enucleation, The absolute indications are refractory disease despite salvage treatment, direct or indirect signs of disease exteriorization, neovascular complications associated with untreatable ischemic retinopathy, and phthisis bulbi. So moving to the next question would be, which wavelength of diode laser is used for transpupillary thermotherapy to treat retinoblastoma? I think this is the easiest question that we have on this panel today. And look at the speed at which it popped up. That would be 810, 940, 980, or 1318 nanometers. And yes, all the 4 wavelengths are available. That is correct. So I was right that this is the easiest question that we have here. And the speed matters. So that's why we have new changes in the scoreboard. So TTT as primary or secondary focal treatment can be utilized. As primary treatment is in this picture, you can see is in group A, or and in secondary treatment is when you have minimal residual tumor as seen in the second picture. Which sport is this retinoblastoma pioneer known to be most associated with? Football, basketball, baseball, or volleyball? Well, I tried to take the childhood picture to strike out the resemblance. Well, yes, the majority are right. The answer is basketball. And RB Boy is definitely on a high streak of answers. And moving on to the explanation, that was Dr. Carol Lally Shields. And she recently won the Theodore Roosevelt Award in 2023. And she's known for her passion for basketball, but has been an expert in nearly every sport since childhood. Next question is, which of the following are proven factors predictive of subretinal seed recurrence? That would be patient age less than 12 months, tumor base less than 15 mm, both of the above, or none of the above. Be slow while answering this question because you might just make a tiny mistake. As I said, take your time in answering. Answer is not both of the above, and I'll explain how. Let's see what the scoreboard has. We have Control, Alt, Delete climbing up. And the explanation actually is that the younger age is 2 times at higher risk for subretinal seed recurrence, and the tumor base more than 15 mm. Those lesions are at 3.3 times higher risk of subretinal seed recurrence. And this was a paper by Shields et al., where the predictive factors for recurrence of retinal tumors, vitreous seeds, and subretinal seeds following chemoreduction were discussed. Next question is, according to the American Brachytherapy Society Ocular Oncology Task Force guidelines, which photon emitter has the longest half-life? Again, pause and read. Ruthenium 106, iodine 125, palladium 103, or strontium 90. Well, I had tweaked the question a little bit, and it did say photon emitters, and I think a lot of you missed that. But let's see what's on the scoreboard now. That's a good streak by RB Boy. Well, the photon emitters are iodine, palladium, and cesium. Ruthenium also does not have the longest half-life. Strontium does, but yes, out of all of them, the photon emitter, that was iodine, had the longest half-life. Which was the first drug used for intravitreal chemotherapy for retinoblastoma? That would be nitrogen mustard, thiotepa, cyclophosphamide, or melphalan. Now, this is a very easy question because I think if many of you are part of quizzes, then this has been a very repetitive question. Well, the answer is thiotepa, and that was the first drug ever used. And we have a good streak going on here. And it was introduced in 1961 by Erickson and Rosengren. And it's a historical case series of 6 eyes treated with intravitreal injection of 0.3 to 0.4 millimeter cube thiotepa injection with a 0.3 mm fine cannula through the posterior part of ciliary body. And this has been described by Dr. Manju Daveda in her paper as well. So who first introduced the technique for intravitreal chemotherapy? By selective ophthalmic artery infusion. Be very careful about the wordings that have been used in the question. Take your time and answer. It was Rees et al., Kiribuchi et al., Kaneko et al., or Goben et al. Well, that's interesting. That is correct answer. That is Kaneko et al. And we have new names climbing up. It's interesting to see how the scoreboard has RB boy, RB, and RB. And and we have control or delete and Samiksha on the same positions in the scoreboard. So selective ophthalmic artery infusion, the game changer, was introduced by Yamine, Kaneko, and Mori. And they used melphalan for IAC in retinoblastoma with a success rate of 97.5%. This was not the first intraarterial chemotherapy, but it was definitely the first selective ophthalmic artery infusion because they were the ones who described the system. A 16-month-old with total retinal detachment underwent vitrectomy by a retinal surgeon and presented with proptosis. What's the diagnosis? And it has been very well explained by Dr. Feroz in her lecture also. And primary orbital retinoblastoma, secondary orbital retinoblastoma, accidental retinoblastoma, or overt retinoblastoma. Easy words, tiny twists. And I think majority of you will get it right. Exactly. So it is the accidental retinoblastoma. And we have a very stagnant scoreboard with new names popping on and off. So it's a very important thing to know, and that is that primary orbital retinoblastoma is the baseline clinical manifestation, and secondary is recurrence after enucleation. Accidental is inadvertent perforation or intraocular surgery in unsuspected retinoblastoma. Therefore, wherever you have a doubt of retinoblastoma, any intraocular surgery should be avoided. And overt is when it's an intraoperative finding, and that is often extraocular or optic nerve extension. And microscopic is when it is histopathologically proven. And this was the classification given by Honavar et al. And this is a very interesting paper, an update on orbital retinoblastoma. So moving on to the next question, to whom are these histopathological diagrams attributed to? That would be Flexner, Wintersteiner, Homer, or Wright. I know the options are not fair. I can see by the speed of answering that everyone's wondering about which one should they choose. Just pick one faster. That's good and interesting. And that was a difficult question, I must admit. It's Wintersteiner who actually drew these diagrams. So the scoreboard remains the same. And we have the Flexner Wintersteiner rosette. And it was drawn by Wintersteiner and described by both of them. It's a row of columnar cells, eosinophilic cytoplasm, peripheral nuclei are arranged radially, central lumen with a refractile membrane, and that describes the histopathological features. Moving on to the next question, at the 2023 AAO, which retinoblastoma legend gave the famous Zimmerman lecture? Was it Dr. Carol Shields, Dr. Matthew Wilson, Dr. Dan Gombos, or Dr. Ralph Eagle? That is correct, but a lot of people did not get that answer right. It is Dr. Dan Gombos who gave the most recent lecture, and that was a game changer for the scoreboard. And he spoke on liquid biopsy and personalized medicine, the keys that will cure ocular cancer. All the other three options had given the Zimmerman lecture in the past, and that was in 2008 by Dr. Ralph Eagle, 2013 by Dr. Carol Shields, and 2018 by Dr. Matthew Wilson, and they all were the panelists today. Next question is, what is the reported incidence of second non-ocular tumors in retinoblastoma survivors at 10 years? This was also pretty much a very important landmark paper, and that is 10%, 20%, 30%, and 40%. I know this is a tough question, but the purpose is to introduce the concept of secondary tumors. Wow, very good that everybody got, a majority of you all got the answer right, and that is 20%. And the paper was by Abramson et al., and they had shown that at 10 years follow-up, it's a prediction that at 10 years, the patients might, 20% patients might have second non-ocular tumors, and at 20 years, it could be 50%, and at 30 years, could be 90%. And the most common tumor that can occur is sarcoma. Which pathologist described the exophytic and endophytic types of retinoblastoma? And these are the two. And it was described by Flexner, Wintersteiner, Homer, or Hirschberg. The way I have patterned the options, I think it should be easy for everyone to guess it. See, that's right. The Hirschberg is the answer. And it was described by Hirschberg in the past. And the next question is, Dr. Alfred Knudsen is known for understanding the molecular mechanism of which of the following? This is a very easy question. And the options are tuberous sclerosis, retinoblastoma, neurofibromatosis, or all of the above. This study was first carried out at MD Anderson Institute, if I may stand corrected. The answer is all of the above. The two-head hypothesis was definitely for retinoblastoma. And let's see how the scoreboard changes. We have an upper lid riser, and that is climbing up. And this is the cover page of the special issue of Genes, Chromosomes, and Cancer, which was released on Knudsen's 80th birthday. And Knudsen definitely gave the genetic mechanism for all three diseases. In fact, he gave the tuberous sclerosis complex first, followed by retinoblastoma, and then the neurofibromatosis. So all were described by him. And in which edition of AJCC TNM's classification was H introduced? And this has been already addressed, so I think you all should be quick with it. And that would be the 7th, 8th, 9th, or 10th. I'm sorry for that part. Anybody who wants to choose 9 can go for the C option. That is perfect. So everybody was listening to Dr. Reddy. So that is, we have AGCC 8 classification where H was introduced. And we have a new name on the scoreboard by Gautamar. So moving on to the next question, this historical image led to the introduction of which remarkable technique? That would be ultrasound biomicroscopy, cryotherapy, transpupillary thermotherapy, or ultrasonography. Yeah, this is a tough one, but it's a very important historical paper that was released back in the days. Oh, that is very interesting that everybody got it right. That is the transpupillary thermotherapy. And we have a climber. So that was given by J.J. Lagendijk, and this was introduced, basically he introduced the concept of transpupillary thermotherapy in retinoblastoma. Ustrovitz gave the concept of TTT in choroidal melanoma to begin with, and Lagendijk gave two cases that had successful treatment. One case had anterior retinoblastoma, the second case had multiple retinoblastoma recurrence, and this is the picture from his paper. Which drug is delivered via the step RB technique? This is the episcleral plaque, and this is the last question of the day. So this is a very easy question though. Would it be carboplatin, melphalan, topotecan, or none of the above? Step RB technique is still in the trial process, but has shown very good results. The correct answer is topotecan. And that is where the term STEP comes from. T there stands for topotecan episcleral retinoblastoma technique. So this is all that we have, and let's see what's on the podium. So the third position is by Samiksha, and the second position is by Control-Alt-Delete, and the first position is by RB Boy. It's interesting that we have these names, and the runners-up are Gautamar and Dr. Prabjot. And I request all of you to please email me at rolikabansal@gmail.com, and so that we can communicate regarding it. Or you can even email santosh.honavar@gmail.com, and we can see how that is going. So over to you, Mritika.
Thank you, Rolika. That was definitely a pretty exciting quiz. Quite dealt with a lot of history. All right. Thank you so much to all the speakers and the discussants for joining us for this webinar. Thank you, Dr. Ashwin and Dr. Gombos, for sticking around till the very end. We really appreciate that. And Dr. Gombos, if you could just give the last few words and we'll end the symposium.
I think it was really an amazing symposium with some world-class speakers. And I think, if nothing else, it shows that through collaborative thought, as Ashwin had pointed out, there is an exceptionally bright future. And regardless of what limitations one has within their own countries, we see individual countries, particularly countries like India, using its amazing resources to obtain outcomes that we never could have imagined 20, 30 years ago. And we can only imagine that that will continue to progress significantly over the next decade. So a great talk, and inviting you all, of course, to the International Society of Ocular Oncology in Goa. The second time ISOO will be in India. It was in 2004 in Hyderabad with an enormous local cohort of Indian ophthalmologists coming at that meeting. And so we invite you all, enthusiastically invite you all to come and present. And I look forward to seeing you all there.
Thank you so much. And all right, bye-bye then.